Good morning to everyone. So we are going to start with the hypolipidemic drug. So when I'm going to tell hypolipidemic drug, you know that the lipids, okay, these lipids are going to be a very important thing that is going to cause atherosclerosis, all your cardiovascular diseases. So your lipids, especially your lipoprotein A, and your LDL is going to pose a great threat and a risk factor for development of your coronary artery disease as well as your cardiovascular disorders. So that is the reason why this chapter is very important. Okay, once this chapter gets over, you will get a brief idea how to use statin, for whom statin must be given, and all those individual topics. Okay, hope you all remember your familial hypercholesterolemia. It's a topic which you would have read a 5-mark question from your biochemistry. Hope you would have remembering it. But if you are not remembering also, I'll take a brief revision of what that was discussed in the biochemistry in the previous year. Okay, so let us start with the discussion, guys. Come on. So first topic is going to be hypolipidemic drug. So what is a statin? So we are going to have your rosuvastatin, atorvastatin. What is the statins? They are nothing but the HMG-CoA reductase. They are nothing but HMG-CoA reductase. So what happens in HMG-CoA reductase? You all know that for the cholesterol synthesis, you need a HMG-CoA reductase enzyme. So the HMG-CoA reductase enzyme is necessary for the cholesterol synthesis from the free fatty acids. Now, this cholesterol synthesis, which requires HMG-CoA reductase, can be inhibited by the drug called as statins. When you're going to inhibit the drug HMG-CoA reductase, what happens? The overall amount of cholesterol present in the body will be reduced. But what happens after the cholesterol synthesis? This cholesterol has to be taken up by your LDL. LDL is a transporter of your cholesterol. So this LDL is going to have a receptor both in the blood vessel as well as in your liver. Now the blood vessel is coming to your liver. You are going to have a LDL receptor. You are going to have LDL in your blood. That LDL is going to go and attach to the LDL receptor. Once it is going to attach with the receptor, what happens? It is going to take over your cholesterol. And then it is going to go into the blood supply and it is going to supply your peripheral areas. In peripheral areas, what happens is this LDL will be deposited then and there when there is an excessive amount of LDL present. And back to back again, after the LDL is going to supply everywhere in your body, it is going to come back to your liver, and in the liver you're going to again have a receptor called as PCSK9. This PCSK9, what happens is this is going to incline with your liver. And after the inclination, what happens? It is going to deposit all the LPD, that is going to be LDL. So first the cholesterol. But again, return reduced form. All your LDL is going to become reduced form. Remember, the LDL is going to consist of your low density lipoproteins. This low density lipoproteins are going to come back and again get deposited in the liver. When all this low density lipoprotein has come and deposit in your liver, what happens? It will lead to fatty liver. So what you can do is either you can prevent the cholesterol synthesis itself by giving a statin drug, or you can prevent this PCSK9 receptor. When you're going to prevent this PCSK9, what happens? It is going to prevent your LDL, which is loaded with the low density lipoprotein, which is going to be loaded with your lipid, back to your liver. That can be prevented. Or the inclination, which is going to occur, inclisiran, which is going to be occurring, which will help your inclination, which is going to help in the protein synthesis of this PCSK9 receptor. That can be prevented. So there are 3 areas which we are going to target. One at the receptor. Second one, the target is going to be at the HMG-CoA reductase. The third one is going to be this PCSK9 production. Okay, so PCSK9 is going to be LDL-C receptor, which is going to help in degradation. So when you're going to give this PCSK9 inhibitor, what happens? Your LDL-C, which is going to carry your lipid, will not get destructed. So if it is not getting destructed, what happens? The lipids will not come out of your LDL lipoprotein, so that the lipids will not be deposited in your liver. The ultimate aim is lipids must not get deposited in the liver. That is our ultimate aim. So that we can achieve. Now coming back to the each and every individual thing, we also have one more drug, the one more receptor that is going to be targeted. That is going to be NPC1L1. NPC1L1 is going to be the one that helps in the cholesterol movement across your liver. That can be prevented by ezetimibe. Ezetimibe is going to be given alone. So they are going to be statin plus emicidib. If you are going to give, that is going to have a synergetic effect. So that will have a very good effect. Now coming to the familial hypercholesterolemia. So what happens in the familial hypercholesterolemia? Familial hypercholesterolemia is nothing but when this LDL-C receptor is going to be failing. When this LDL-C receptor is going to be failing, what happens is there is no proper exchange of lipid. When there is no proper exchange of lipid in your liver, what happens is they get deposited in the unnecessary or unimportant or insignificant places. When they're going to deposit in pathological places, what happens? They are going to block the blood vessels. They are going to block the area of blood supply to particular area, particular organ. That is going to lead to ischemia and necrosis. This is the same happening in the atherosclerotic causing MI. So what happens in a myocardial infarction? There is going to be a deposition of this LDL where it is going to be deposited in your coronary vessels. When they are going to be depositing in the coronary vessels, what happens? It is going to cause a significant reduction in the supply of blood and oxygen to the particular area. That is going to lead to the problem. Hope it is clear for you. So what are the drugs you are going to give? Number one, mipomersen. What is mipomersen? It is nothing but they are antisense oligonucleotide. That is, they are going to be against, there is going to be a action against your ApoB100. ApoB100 is also one type of lipoprotein which is going to carry your lipid. That is going to be inhibited. Now coming to the low metapide. What is low metapide? It is nothing but mitochondrial transfer protein inhibitor. Okay, but remember, a potent drug of choice for LDL-C lowering, for reducing the LDL cholesterol in your body, what is going to be the best agent? That is going to be your pitvastatin and your rosuvastatin and atorvastatin. From the high intensity statin to the low intensity statin, it is going to be a pitvastatin followed by your rosuvastatin followed by your atorvastatin. So what is the drug of choice in hyperlipoproteinemia? So in a type 2A or type 2B, in all these conditions, the potent drug of choice is going to be a statin. Okay, now the question comes, if LDL is going to be less than 190, okay, you're going to go for statin drugs. Okay, when it is going to be more than 190, you go for statin drugs. Or when the LDL-C level is less than 190, but the patient is having a atherosclerotic cardiovascular disease risk factor or diabetic mellitus risk factor, then you're going to go for a statin drug. Or if the patient have a previous history of MI, angina, stroke, in that case also what you will do is, you will give statin in the patient. You will be giving statin in the patient. So is it clear? Okay, so when you have to give statin, that's what I'm telling you. What are the side effects of statins? So statins usage will be leading to myopathy. What is myopathy? There is going to be a pain or inflammation in your muscles, and that will lead to rhabdomyolysis. Breakdown of your muscle fibers can occur. This leads to severe muscle pain, pink urine, and rise in the CK level. This is going to cause rise in the CK level. Next, coming to the statins. Remember, statins are going to be an enzyme involved. That is going to be a CYP3A4. You already read many drugs which are going to act as an inducer of your cytochrome P3A4. What are those drugs? Number one, erythromycin, clarithromycin. Number two, azole group of drugs. Number three, ritonavir. Number four, you have your amiodarone. Number five, gemfibrozil. Number six, niacin. How to remember this, sir? How I am going to remember this? Remember year GAN. Okay, year GAN. So E stands for erythromycin, A stands for azole, R stands for ritonavir, and you're going to have G stands for gemfibrozil. Then you're going to have A stands for amiodarone, and the N stands for niacin. Remember, pravastatin is more comfortable than your rosuvastatin because they are not metabolized by your cytochrome P3A4. They are very safe with the cytochrome P3A4 inhibitors like your erythromycin, azole, ritonavir. Idoda sethi you can combine and give. But whereas if you want to give rosuvastatin or atorvastatin, what is the problem is atorvastatin is going to be broken down by this cytochrome P3A4. The cytochrome P3A4, what happens? It gets inhibited by all these ear GAN drugs. When they are going to be inhibited by ear GAN drugs, what happens? There is going to be more statins that are going to be present in the body. So it is going to lead to toxicity. That is the reason why you will not give statin along with these drugs. Remember, in hepatitis, it is going to cause rise in the AST and ALT level. That is a very important point. And insulin resistance will be caused by the statin. So, okay, so that is going to be insulin resistance will be inhibited. So there is going to be a insulin resistance. So therefore what happens is this is not given in case of diabetic mellitus. So statins can itself lead to diabetic mellitus. So you should be very careful while prescribing statins. Now coming to the contraindication. In which condition you will contraindicate or you will not give your statin? Number one, pregnancy and lactation. Very, very important. In pregnancy or lactation, you are not supposed to give statins. Instead, what you will be giving? Bile acid binding resins you will be giving. What are the bile acid binding resins? Number one, choletyramine and your cholecelvamin. Okay, so you're going to have your choletyramine. So this choletyramine is a very important drug because they're going to your bile salt is going to be binded in GIT and it is going to excrete the fat along with your bile salt by your fecus. Okay, wow. So that is why this is important and it is contraindicated in high triglyceride level. In high triglyceride level, what happens if you're going to do this? This will cause a malabsorption syndrome. This will cause a very similar looking to malabsorption syndrome. There will be blotting in the patient because fat is going to be excreted via your feces. So what happens? The patient will be having a side effects such as blotting will be present. Okay, so you should be very careful. Next is going to be your fibrates. Do you remember where else we saw this PPAR alpha agonist? Can you recall and tell me? Somewhere we studied this PPAR yesterday. Can you recall and tell me where did we study this PPAR? Yesterday we studied in some area, we studied about this PPAR. Can someone recall and tell me where we studied this PPAR? PPAR. Instead of alpha, we saw PPAR gamma. Exactly in the diabetes. So it is going to be a thiazolidinedione. So it is going to be a PPAR gamma receptors. Here it is going to be PPAR alpha receptors. So you need to know the difference between those two. Okay. So here what happens? PPAR alpha, it is going to be present in the adipocytes. So what happens? It is going to be nothing but your lipoprotein lipase. What it does is it will be breaking down your triglyceride into your free fatty acid and glycerol. It is going to break down your free fatty acid and your glycerol. That is the function. So that is going to be the function of your lipoprotein lipase. Now, what is going to be a drug you're going to give? You're going to give the drug called as fibrates. What is the action of this fibrates? This fibrates is going to have a very peculiar action. What it is? This fibrates, they are nothing but they are going to activate your PPAR alpha. Whenever there is activation of PPAR alpha, what happens? All your triglycerides are going to be broken down into free fatty acid and glycerol. So this you can give in hypertriglyceridemia or chylomicronemia. That is going to be your type 3 lipoproteinemia. In type 3, you're going to give fibrates. And when it is going to be your familial hyperproteinemia type 1, in type 1, you go for mispomersen and lomtopide. Lomtopide you are going to give in the type 1 hypercholesterolemia. In your type 3 hypercholesterolemia, you go for the fibrates. So what are the examples of fibrate? Just note it down below this. Number one is going to be your gemfibrocil. Number one, it is gemfibrocil. Number two, it is going to be your bezafibrate. Number three, you're going to have the one which is most commonly used. That is going to be your fenofibrate. Fenofibrate is the most common drug which is used as a fibrate drugs. Okay, what are the side effects you're going to have? The important side effects you have is going to be myopathy. So very similar to that of your HMG-CoE reductase, you're going to have myopathy. So you should never combine gemfibrozil with statin because statin is also going to cause myopathy and it is going to cause rhabdomyolysis. And your gemfibrozil will also cause myopathy. Therefore, you're not going to combine both. Next, you're going to have a clofibrate. What is clofibrate? Clofibrate is also one of the fibrate drugs. So add our fourth one, clofibrate. This clofibrate is a very important thing that can lead to gallstone. Fenofibrate, they can cause uricose-uric drug. That is, they raise the urea level in your body. So that is another problem with the fenofibrate. So what is dual PPAR alpha or gamma agonist? So dual PPAR alpha gamma agonist, nothing but when you're going to have a hypercholesterolemia patient and the patient is also going to have diabetes, instead of giving separate drug for PPAR gamma and PPAR alpha activator, what we are going to do is we are going to give it as a single drug. So what we are going to do? We are going to give it as a single drug. What is the drug that you are going to give as a single drug? That is going to be your saroglitazar. Saroglitazar, like this. Remember, saroglitazar. Can you tell me what is going to be example of your PPAR gamma? Can someone put in the chat box what is the example of PPAR gamma activator? Can you put a drug? Can you put an example for your PPAR gamma? Yesterday we discussed in endocrinology. Afif was there yesterday. I think even Vaidishwaran was there yesterday. Pal Pandi was there yesterday. I think these people were there yesterday, right? Can you tell me in the chat box? Yeah, PO glitazone. PO glitazone. So how to remember? Can you see here? Here also you're going to have glita in it. So that glita is here also you're going to have glita. So you're going to have glita even in the saroglitazar. So this drug is going to be nothing but saroglitazole. So glitan irundale, it is going to be PPAR gamma agonist. So you're going to have a dual PPAR, PPAR alpha as well as PPAR gamma. So what is going to be the example for this? This is going to be your saroglitazar. This is going to be treatment in the condition called diabetic dyslipidemia. Are you all clear with this? Are you all clear with this diabetic dyslipidemia? What is the drug you are going to give? Excellent, Dinesh. Thank you for answering. Next, finally, we are going to have the last part of your hypolipidemic drug. That is going to be your niacin. So niacin is nothing but your nicotinic acid. They are going to inhibit the HSL, that is hormone sensitive lipase. When it is going to inhibit the hormone sensitive lipase, what happens is there's a reduced level of free fatty acid supply. So free fatty acid supply to your liver when you're going to inhibit the hormone sensitive lipase. Because of that, what happens? The production of triglyceride itself is going to get reduced. That is the importance of your hormone sensitive lipase inhibition. So, and we are going to also niacin does is, it is going to break down your HDL cholesterol. So, it is going to break down your HDL cholesterol. So, in which condition you are going to avoid this niacin? So, remember, avoid PG diploma. So, what are the drugs you are going to avoid? PG diploma. P stands for your peptic ulcer. So, it is going to cause dyspepsia. So, remember, these are the contraindications. These are going to be the side effects. It is going to cause dyspepsia. Therefore, you are going to avoid in the peptic ulcer. It is going to cause hyperuricemia. So, you are going to avoid it in the gout. PG. G stands for gout. And hyperglycemia. So, you are going to avoid it in the diabetic mellitus. So, you are going to avoid in the diabetic mellitus. And increase in prostaglandin synthesis. So, what is the solution for it? You can add aspirin. Aspirin is a prostaglandin inhibitor. So, you are going to add aspirin. And finally, acanthosis nigrans. Acanthosis nigrans, what happens? It is going to cause, it is nothing but deposition of your insulin resistance. Because of insulin resistance in the adipocytes, because of insulin resistance in the skin, what happens is there is a deposition of pigmentation in all your neck and the ankle, in your axillary area. So there's a blackish pigmentation that is called as acanthosis nigrans. Hope it is clear. Now finally, lipoprotein A, you would have read in pathology that it is a very important risk factor for coronary artery disease. So this is a very important risk factor for coronary artery disease. What is the drug you are going to give? There we will not give statin. Instead, we will be giving niacin and PCK9 inhibitor. We will go for PCK9 inhibitor. I'll give you a last moment to revision. So what are the adverse effect of statins? Are we going to remember it by using the mnemonic HMG CoA reductase inhibitor. That is your statin, right? H stands for hepatotoxicity. Copy it down. H stands for hepatotoxicity or otherwise headache. Both are going to be caused by your statin. Okay. Number 2, M stands for myopathy. It is going to cause myopathy. And what is your G stands for? G stands for it is going to cause GIT upset. And what is going to be your CoA? It is nothing but it is going to lead to cataract. It will be leading to cataract. And what is red? Its R stands for there's increased risk of. D stands for diabetic mellitus. So there's an increased risk of diabetic mellitus. And what is inhibitor? It is also going to cause inhibition of your or breakdown of your muscles. So it is going to lead to rhabdomyolysis. Rhabdomyolysis. These are going to be the important side effects. Myolysis, these are going to be the side effects of your statin. With this, we are completing hypolipidemic drug. Do you have any doubt till now? Do you have any doubt till now? Can someone post in the chat box? From yesterday, we are seeing antimicrobials is over. We have completed central nervous system drugs. We have completed endocrinology. We have completed hematology. And today, we are going to move towards the anti-cancer drug. If you have any doubt till now, you can post it in the chat box. Or else I'm going to move towards the next one. That is going to be anti-cancer drug. Do you have any doubt? Do you have any doubt, guys? PCSK9. what is PCSK9 is? See, PCSK, I think you joined in the middle and in the beginning you were not there. See, PCSK9 is nothing but it is a receptor that is going to be, it is a protein that is going to carry your LDL and deposit in your liver. So this PCSK9 is produced by your liver, number one. It is produced by liver. And what happens is, after production at the level of liver, they are going to be released out. This is going to carry your LDL, from which is going to be loaded with your cholesterol. From all the area, it is going to take back the remaining lipids and it is going to bring it back to the liver. So on the bring back pandrappa, and the liver LDL receptor and the LDL which is present in the blood has to be carried back into your liver. Who is going to carry that back? That is going to be your PCSK9. PCSK9 is the one that is going to carry back your lipid from your blood supply. From your blood, it is going to carry back your LDL, which is loaded with triglyceride, into your liver. So that is called as PCSK9. How we are going to inhibit PCSK9? By two methods. You can give a direct antibody against PCSK9, number one. Or you can do is, you can prevent the production of PCSK9 at the level of liver. Okay, these are the two drugs which are going to be PCSK9. Now are you clear? Is it clear, Afif? What is PCSK9 inhibitor? Are you clear with PCSK9 inhibitor, Afif? Can you confirm so that I can move towards the next one? Others? Any doubt? No, right? Shall I move towards anti-cancer drug? Okay, so now we are going to move towards the anti-cancer drug, a very, very important topic from exam point of view, because you need to understand this topic pretty well in order to apply this in your exam. So you can never mug up this anti-cancer drug basically. So you're going to read. See, what happens is, for a cell to multiply, what do you need? You need a cell cycle to take place. So you need a cell cycle to take place. Okay, so either what you can do, how you are going to inhibit the production of new cells. Either you can go for a conventional cell that is going to directly kill your dividing cells. They are going to directly kill your dividing cells. Or what you can do is, you can specifically target some drug. So what you can do, you can specifically target some drug. What are the drugs? Either you can give a monoclonal antibody against the production of any cell. Or what you can do, you can inhibit this protein kinase. You all know that protein kinase is going to play a very important role in the cell cycle. So that you can prevent. Or what you can do, you have some checkpoints in your body. So you all know that your cell cycle is going to be consisting of G1 phase, S phase, G2 phase and M phase. Idhila ovvoru area nama independent we can target and we can inhibit. Or the fourth one is going to be your hormonal drugs. You can go for some hormonal drugs. So this is going to be the basic idea of your anti-cancer. So what is a cancer? It is going to be there is an increase in the tumor pro-tumor, that is going to be your proto-oncogene. And what happens? There is a reduction in the tumor suppressor gene. Proto-oncogene is going to be more, tumor suppressor gene is going to be less, and that is what is leading to the so-called cancer. Now, how you are going to target the anti-cancer drugs? So, either you are going to kill all the rapidly dividing cells, all the cells which are present in the mitosis. Or what you can do, you can target specific cell by giving a CD marker. Using the CD marker, we are going to develop an antibody against that cluster differentiation cell. Or you can go for an immune checkpoint inhibitor, or finally the hormonal drugs. Clear, right? So those who have attended my pathology session, please correlate with the pathology now. We have read many tumors in pathology. In the systemic pathology, we have read many tumors. Now I will be correlating, especially your hematology. Hematology and your anti-cancer drugs, which we are going to read in pharmacology, must be correlated. Okay, right? So now moving towards the cell cycle, the first thing what you're going to understand is, you're going to have a G1. So first you're going to have a daughter cell. Okay, which is going to be obtained. So that has to be, first what you're going to do, you're going to synthesis phase. So first phase which is going to be present is going to be S phase, that is your synthesis phase. This synthesis phase, what it does is, it is going to prepare your DNA. It is going to prepare all your enzymes, RNA polymerase, DNA polymerase. You need many enzymes for co-action, isn't it? So those enzymes has to be prepared. It has to bed, it has to maintain some conditions in your cell so that the cell division is going to occur. And it has to produce some energy. It has to prepare some energy. It has to prepare a ATP. It has to prepare a glucose. And all these things are required for a proper ATP synthesis. So that is prepared in the S phase. After S phase, what happens? You are going to have your G2 phase. So in G2 phase, what happens? There is going to be a daughter cell. What happens? This G2 cells is going to produce your parent cell. This is going to produce a parent cell and a duplicate copy of your parent cell. This is how it happens. So now what you can do? Okay, basically now what you can basically do is you can inhibit certain step in your cell cycle. What we are going to do, we are going to just inhibit certain areas of your cell cycle so that you will be targeting and you are going to remove the cell cycle. You are going to prevent the cell cycle from going. Okay, so what are those mechanisms? How we are going to perform? Okay, first one you're going to read is going to be cell cycle non-specific drug. So it can act on any cell cycle. So cell cycle G phase la da irukano and mailam kedaiyadu. In the phase of the cell cycle la venalum these drugs can act. Okay, these drugs can act at any phase of your cell cycle. Okay, va. So that is going to be your alkylating agent. Number 1. Number 2, you're going to have a platinum component. Number 3, you're going to have anti-tumor antibiotics. What are the 3 things? Repeat along with me. Cell cycle non-specific drugs that can act on any phase of your cell cycle. That can act on any phase of your cell cycle. What are those drugs? Alkylating agent. What are those drugs? Alkylating agent. Okay, wow. And then platinum compound, and you're going to have your antibiotic. That is going to be your anti-tumor antibiotic. First one, what we are going to see is a alkylating agent. See, what does your alkylating agent does? So it is going to cause alkalization of your DNA. At what site? At N7 site of your DNA. So at N7 site of DNA, okay, nitrogens in the seventh place. What it does is it is going to inhibit or it is going to cause inactivation of the N7 of your cell cycle. Because of inactivation of N7, what is going to happen? There is going to be a DNA damage. Okay, that's all. Very easy, I'm telling. So what it is going to do? It is going to cause alkalization of your N7. Okay, it is going to cause alkalization of your DNA at what place? At N7. So because of the alkalinization of your N7, okay, what happens is it is going to cause DNA damage. Okay, if you are going to have a short note question, how to write? First, put the heading as alkylating agent. Write it as mechanism of action. What is mechanism of action? Now, this alkylating agent which you are going to give is going to donate. It is going to donate alkyl group. Okay, it is going to donate alkyl group. So this is going to go and bind with the N7 of your guanine base pair. It is going to bind with the N7 of guanine base pair. So because of this, what happens is there's a cross linking between the 2 carbon atoms. So here you're going to have a carbon atom. Here you're going to have a carbon atom. There is going to be a cross linking. This leads to cross linking. So whenever there's a cross linking, what happens? It is going to inhibit your DNA replication. It is going to inhibit your DNA replication. Because of this, what happens? There is an inhibition of mitosis. There is an inhibition of mitosis. So what happens whenever there is an inhibition of mitosis? Remember, first there is going to be a G1 phase. After G1, you're going to have synthesis of DNA, that is S phase. Then you're going to have G2 phase. Then you're going to have M stands for mitosis. M stands for mitosis. Here what happens? Your mitosis phase is also going to be affected, whereas the synthesis of DNA is also going to be affected. Both areas are going to be affected. So remember, alkylating agent can affect all the stages of your cell cycle, except, this is a very important point. So your alkylating agent, they can act on all the places of your cell cycle except one place, that is going to be your G1 phase. So in G1 phase alone, your alkylating agent does not act. Remember, alkylating agent will be acting on, it is going to act on your S phase, it is going to act on the G2 phase, it is going to act on the M phase, except which phase? That is going to be your G1 phase. In G1 phase, your alkylating agent does not act. That's why you call this as a cell cycle non-specific, because we are not targeting particular step of your cell cycle. It is just going to act on your S phase, it is going to act on the G2 phase, it is going to act on the M phase. Clear, right? So what is how to remember the side effects? Remember LG stamp. So you have LG company, right? LG stamp. What is LG stamp? L stands for okay, you're going to have a L stands for, you're going to have leucomeningic potential. They can actually go for leucomogenic potential. It's leucomogenic potential. That means there is a rise in the WBC. There is a rise in the WBC. Leukocytes will be increased. Next, you're going to have G stands for gastrointestinal toxicity. G stands for gastrointestinal toxicity. S stands for sterility. S stands for sterility. T stands for teratogenic. T stands for teratogenic, A stands for alopecia, and your M stands for marrow in marrow failure. So there is going to be a decrease in the production at the level of marrow, and P stands for pulmonary fibrosis. Can you all repeat along with me? What is LG stand? L stands for leukemogenic potential, G stands for gastrointestinal manifestations, okay, S stands for sterility, and T stands for teratogenic, A stands for alopecia, M stands for marrow suppression, and P stands for pulmonary fibrosis. This is all about your alkylating agent. So what you have to remember among the alkylating agent is, you have to remember there are several group of drugs present in the alkylating agent. Among them, first one is going to be nitrogen mustard. So you would have all remember cyclophosphamide. This is a one drug that you're going to commonly see everywhere. But remember, cyclophosphamide is just a prodrug. When you're going to give the cyclophosphamide, they are going to get converted into 4-hydroxyphosphamide. They are going to get converted into 4-hydroxyphosphamide. So this 4-hydroxyphosphamide is going to get is going to act which place? It is going to act at the GS phase, G2 phase, M phase. Very similar, because these all are going to be an alkylating agent. So the mechanism of action is going to remain the same throughout all your alkylating agent. But what happens in nitrogen mustard? This 4-hydroxyphosphamide, they are going to get metabolized into substance called as acrokin. This acrokin is a very toxic material. They will be leading to hemorrhagic cystitis. They will be leading hemorrhagic cystitis. That is the reason why cyclophosphamide is not commonly used nowadays. I'll tell you what mechanism it is going to cause. You have something called as acrolein. Okay, it's acrolein. This acrolein, what happens? They are going to be attaching in the bladder. If this is going to be a bladder, what happens? It is going to be attaching with your bladder tissues. When they are going to attach with the bladder tissues, what happens? They are going to cause hemorrhagic cystitis. They are going to lead to hemorrhagic cystitis. Clear, right? Now coming to what are the usage. You are going to use that in non-Hodgkin's lymphoma. Now can I correlate with the hematology which we did in pathology? Non-Hodgkin's lymphoma, what is the drug regimen? I asked you to remember. CHOP regimen. C stands for cyclophosphamide, H stands for hydroxydoxorubicin, and O stands for oncovin or vincristin, and P stands for prednisolone. So one among them is going to be a cyclophosphamide. We are going to use it. Now, how do you prevent this hemorrhagic cystitis? You are going to also use in vaginous granulomatosis. You are going to use in steroid-dependent nephritic syndrome. You are going to also use it in steroid-dependent nephritic syndrome. You are also going to utilize that in steroid-dependent nephritic syndrome. Okay. So see here, first one we saw is a non-Hodgkin's lymphoma. In non-Hodgkin's lymphoma, you are going to have CHOP regimen. Next, you are going to have your vaginous granulomatosis. Vaginous granulomatosis, drug of choice is going to be your cyclophosphamide. Then steroid-dependent nephrotic syndrome. In these three conditions, you are going to use cyclophosphamide as a drug of choice. Okay, now coming to the next one, hemorrhagic cystitis. Whenever the patient is going to have a hemorrhagic cystitis, what you can give? Okay, you can go for the drug called as Mesna. What this Mesna does is, it is going to bind with your acrolein. And when it is going to bind with the acrolein, it is going to prevent the bleeding hemorrhagic cystitis. So this is going to be the drug of choice which you are going to follow. Clear, right? Next you are going to have is going to be your ifosfamide. So what is this ifosfamide? Ifosfamide is another nitrogen mustard which you are going to use in the testicular cancer. Where will you use your cyclophosphamide? Can you tell me? Can you put in the chat box? What are the uses of cyclophosphamide? 3 uses of cyclophosphamide. Can someone put in the chat box? What are the 3 uses of cyclophosphamide one by one? Can you just type in the chat box? Non-Hodgkin's lymphoma, CHOP regimen, excellent. Number 2. What is number 2? Vaginous granulomatosis, excellent. Number 2. Number 3. Number 3. What is number 3? Steroid. What is number 3? Steroid. Dependent or resistant? Nephrotic syndrome. What type of nephrotic syndrome? It's a steroid-dependent nephrotic syndrome. Okay, remember that. Now moving on to talk about the ifosfamide. Ifosfamide, they are going to use in the testicular cancer. What are the side effects? Again, you are going to have hemorrhagic cystitis in the ifosfamide, in the nephrotoxicity, and it can lead to neurotoxicity. Whenever there is a neurotoxicity, what is the drug of choice you're going to go? You're going to go for methylene blue. You're going to go for methylene blue. Okay, next you are going to go for the meclorethamine. What is the next group of drugs we are going? Meclorethamine. What is this miclorethamine? Remember, miclorethamine is a one drug which we are going to use in the Hodgkin's lymphoma. In non-Hodgkin's lymphoma, you are going to use cyclophosphamide, whereas in Hodgkin's lymphoma, you are going to use miclorethamine. So M stands for miclorethamine, O stands for oncovin, and P stands for prednisolone, and another P for procarbazine. MOP regimen. Remember, Hodgkin's lymphoma, you are going to go for MOP regimen, whereas non-Hodgkin's lymphoma, you are going to go for CHOP regimen. C stands for cyclophosphamide. H stands for, what does H stands for? Can you tell me? What does H stands for? Hydroxydoxorubicin. Hydroxydoxorubicin. And what does O stands for? Oncovin. P stands for prednisolone. Here you have MOP regimen. So what is your Hodgkin's lymphoma? You go for MOP regimen. What is MOP regimen? You are going to go for miclorethamine. Then you are going to go for O stands for oncovin. P stands for prednisolone. Another P stands for your procarbazine. Clear, right? Also, you can go have another drug that is called as chlorambucil. Chlorambucil is used as a CLL. So, in a chronic lymphocytic leukemia, you will go for the drug called as chlorambucil. Okay, next is going to be your mulfalin. So MUL, mulfalin. Mulfalin is a drug which you go for the multiple myeloma. In multiple myeloma, what is the drug of choice? Mulfalin. Mulfalin is utilized in multiple myeloma. Is it clear? In multiple myeloma, what is your drug of choice? You're going to go for the mulfalin. Okay, just take a separate page. I'll just write here itself. 1 minute. Yeah. So just take a fresh page, write, put the heading as multiple myeloma. What happens in the multiple myeloma? You know that there is a production of kappa chain and lambda chain. You're going to have production of light kappa chain and lambda chain. So due to the kappa lambda chain, what happens? They are going to deposit in your glomerular membrane, and that is going to cause membranous glomerulonephropathy or nephritis, and it can also lead to plasma cell. That is going to be a multiple myeloma. What are the drug of choice for your multiple myeloma? So remember, drug of choice for multiple myeloma is first one, you can go for thalidomide. Usually in the previous era, what we were using is thalidomide. Thalidomide was used as a drug of choice. And nowadays, what we are using? We are using proteasome inhibitor. Proteasome inhibitor is nowadays used as a drug of choice. What is your thalidomide? Thalidomide is a immune modulator. It is a immune modulator. Okay, so they are also going to act as a anti-angiogenic. They are going to act as a anti-angiogenic. So what is going to be the use of thalidomide? Thalidomide is going to be used in multiple myeloma. In multiple myeloma, it is used in type 2 lepra reaction. Type 2 lepra reaction. It was used in the graft versus host disease. Graft versus host disease. And number 4 is going to be, we are going to use it in the Bechet's reaction. So we are going to use it in Bechet's reaction. And number 5, we have HIV associated uveitis. These are the area where we will be using your thalidomide. But remember, thalidomide or a side effect, two side effect. Number 1, it will be causing a morning sickness. It will be leading to morning sickness. And what is the second important thing you're going to have? Number 2, it can lead to fecomalia. Fecomalia is an important teratogenic, teratogenicity, and that is the reason why you're going to avoid it in the pregnancy. Teratogenicity, you're going to avoid it in the pregnancy. Clear, right? Now coming to the proteasome inhibitors. Remember, the proteasome inhibitors, you're going to remember by the word zomib. Okay, anything that ends with zomib is going to be proteasome inhibitor. What are the two proteasome inhibitor? Number 1, it is going to be bortezomib. Number 2, you have your carfilzomib. Okay, so bortezomib and carfilzomib. These are the two drugs that are going to be involved as a proteasome inhibitor. A very important point which you must understand. Now moving on to talk about your melphalan. So the third drug which is used in the multiple myeloma is going to be your mulfalin. So mulfalin is also going to be used. This mulfalin is going to be the drug of choice. Mulfalin is a drug of choice. What is the mechanism of action of mulfalin? They are going to inhibit cell cycle non-dependence inhibitor. So it is going to inhibit your G2 phase. It is going to inhibit your S phase. It is going to inhibit your M phase. All the 3 phases are going to be inhibited. So you're going to have your mulfalin, you're going to have thalidomide, you're going to have proteasome inhibitor. These are the three drugs you're going to remember in case of your multiple myeloma. Hope you will never forget the drugs which are given for multiple myeloma: thalidomide, proteasome inhibitor, mulfalin. Among the mulfalin is going to be what group of drug? Alkylating agents. Among alkylating agent, it is going to, what it is going to do? It is going to inhibit your G2 phase, S phase and M phase. It is not involved in the G1 phase. This is what you all to remember. Next, we are going to move towards, next we are going to move towards the nitrosourea. So first we saw is going to be nitrogen mustard. In your alkylating agent itself, first topic which we saw is going to be your nitrogen mustard, and second topic which we are going to see is a nitrosourea. Remember, there is an increase in the lipid solubility. What happens in the nitrosourea? There is going to be increase in the lipid solubility. Therefore, they can cross your blood-brain barrier. So what you can use it? You can use it in all your CNS tumor, because CNS tumor, when you want to treat, that has to pass your blood-brain barrier, isn't it? So only drugs which are lipid soluble can pass your blood-brain barrier and can go. So therefore, nitrosourea is going to be a problem. Can you tell me with this basic details, can you tell me whether nitrosourea is safe in the renal failure patient? Whether nitrosoureas can be used in the renal failure patient? Can someone respond? Can nitrosoureas can be used in the renal failure patient? That is my question. Can we use nitrosourea in renal failure patient? Come on, guys. Yes or no? That's all. Try to answer that yes or no. Whether nitrosourea can be used in the renal failure patient. This is my question. Whether nitrosourea is used in the renal failure patient. Can you tell me? See, nitrosoureas are going to be excreted. This is lipid soluble. If anything that is lipid soluble, they will be excreted by what method? By liver. Therefore, you can give it in the renal failure. It is safe with renal failure. Write it down. They are safe with renal failure. They are not safe with liver failure. They are not safe with the liver failure patient. Okay. So you're going to just correlate. Very simple. When it is a lipid soluble, they will be safe with your renal failure. When they are water soluble, they are very safe with your liver failure. Clear, right? So who is going to excrete? So that is what matters. Okay. Now moving on to talk about the third group of drug, that is going to be your trigine. So now before moving to that, remember this, what are the drugs comes under nitrosourea? Low mustin and your carmustin. Anything that is going to end with mustin. Anything that ends with mustin. Can you tell me what it's going to end in your nitrogen mustard? Nitrogen mustard is going to end with phosphamide. Okay, you have cyclophosphamide, you have ephosphamide. Then you're going to have miclorethamine. Now coming to the chlorambucil and meflon. Now coming to nitrosoureas, it is going to have two drugs, mustin group of drugs. What are the mustin group of drugs? You have low mustin and you have a carmustin. What are the side effects of it? It is going to cause bone marrow suppression. There is a profound or delayed bone marrow suppression which you are going to remember. What are the side effects? So the side effect is bone marrow suppression. Where will you treat it? So you're going to treat the nitrosourea in the patient with a, okay, how do you treat the bone marrow suppression? So you're going to treat the bone marrow suppression in case of nitropenia. You're going to go for filgrastim. So stim stands for stimulator. So there is going to be a stimulation of GSCF. So there is going to be a cluster cell. Okay, GCSF. So it is going to stimulate your GCSF, which is used as a drug of choice in other condition called as, okay, Sagra stim. So you're going to have another drug called as sagramostim. So it is also used as a drug of choice for your neutropenia. So what are the two drugs you're going to give in neutropenia? Number one, filgrastim. And what is the other drug? Sagramostim. These are the two drugs which you're going to give in the bone marrow suppression caused by the nitrosourea. And third thing, it can also cause thrombocytopenia. Whenever there's a thrombocytopenia, what is the drug you're going to give? The drug name is Oprivekine. So this is a drug you're going to give for thrombocytopenia. Now, can you tell me what is a drug given for your neutropenia? Can you tell me what is a drug given for neutropenia? Can you put in the chat box? What are the drugs given for neutropenia? What are the two drugs that are given for neutropenia? Can you put in the chat box? What are the two drugs given in neutropenia? Number one. Come on, guys. Just now I told you. You all know the answer. Come on. Can you put in the chat box? Filgrastim, not stin. It is STIM, stimulator. Filgrastim. What is the other drug? Filgrastim. What is the other drug? Can you put the other drug name? Can you put the other drug name? What is the other drug? SAR. Yes, it stands with SAR. SAR. Can you just recall and tell me what is the other drug? It's not Saratrostin. Again, I will write. So it will also have GRA. So similarly, how you are going to have filgrastim, it is also going to be having a GRA in it, but it is going to be sargramostin. So it is going to be stargramostin. So this is going to be another drug that is going to be given in case of your neutropenia. What is the drug you are going to give in case of thrombocytopenia? Can someone put in the chat box? What is the drug you are going to give in thrombocytopenia? Can you put in the chat box? What is the drug you're going to have in your thrombocytopenia? What is the drug you're going to take in thrombocytopenia? Come on, guys. What are the drug you're going to put in thrombocytopenia? Can you tell me? What are the drug you're going to? Very good. It's a oprivkin. So oprilvikin. So it's ril, not RI, just not RI. It is OPRILVEKIN. Oprilvikin. I'm very sorry. It's oprilvikin. Just change it. It is oprilvikin and not oprivvikin. It is oprilvikin. RILVEKIN. Oprilvikin. Okay, that's going to be your drug of choice in case of thrombocytopenia. Now we are going to have third group of drugs that is going to be your triazines. Triazines are nothing but they are going to inhibit the RNA synthesis or protein synthesis. What it does, it is going to inhibit RNA or protein synthesis. For example, the first drug, procarbazine. Procarbazine, in which area you will use procarbazine? Can you tell me? In which regimen you will use procarbazine? In which disease you will use procarbazine? Can you tell me in which reaction you are going to use procarbazine? In which reaction you will use procarbazine? Can you tell me? It's not Bechet's. Okay, it's what is Bechet's reaction you want to know? Dinesh, do you want to know what is Bechet's reaction? Hodgkin's, yes, of course, correct. Do you want to know what is Bechet's reaction or Bechet's syndrome? Bechet's syndrome is nothing but it is an autoimmune disorder. So Bechet's reaction is nothing but it's a small vessel disease. It is a rheumatology you will be reading. I'll teach you, don't worry. In pathology, I think I have taught you in the cardiovascular system. While I'm discussing cardiovascular system, we discussed this. Bechet's reaction or Bechet's syndrome is nothing but it is autoimmune disorder. It is autoimmune disorder. So this Bechet's syndrome is going to be a side effect of all your alkylating agent. Okay, clear, right? Now moving to discuss about the procarbazine. Procarbazine, it is going to be a drug of choice in case of Hodgkin's lymphoma. In Hodgkin's lymphoma, what is going to be the side effect? So remember, whenever we are going to discuss certain side effect under your nitrosourea, under your miclorethamine, and under your triazine, and what is the meaning is you have that initially we read, right, for your alkylating agent. So we have read a list of side effects for alkylating agent, LG stamp. All that will also be present. Apart from LG stamp, you will also have these side effects. So it's a combination. LG stamp is constant for all your alkylating agent. Apart from it, you have certain side effect extra for each and every drug. That is what we are discussing under the each heading. Okay, procarbazine will be also giving disulfiram like reaction. Do you recall yesterday when we are discussing alcohol? So when we are discussing alcohol, I told you to remember a mnemonic. Can someone put the mnemonic in the group, in the chat box? What are disulfiram reaction? I think Afif was there at that time. Afif was there yesterday while I was discussing about your disulfiram like reaction. Can you put the mnemonic which we wrote there for disulfiram like reaction? We written nice people cut down gin consumption. So I'm asking about the disulfiram like reaction. What you are telling is acetylation. Okay, so acetylation you have sulfur drugs, hydrolysine, isoniazid, and procainamide. That is acetylation. Here I'm asking that is going to cause SLE. Now I'm asking is disulfiram like reaction. How do you remember disulfiram like reaction? N stands for nitrofurantoin. N stands for nitrofurantoin. And what is P stands for? P stands for your procarbazine. Procarbazine. And what is C stands for? Chlorpropamide. Chlorpropamide. Okay, what is chlorpropamide? Someone, can you tell me what is chlorpropamide? Can you tell me what is chlorpropamide? Can someone tell in the chat box what is chlorpropamide? This we have discussed in endocrinology. Chlorpropamide. Can you tell me what is chlorpropamide? Someone, guess. Guess, guys. G stands for your griseofulvin, griseofulvin. And what is your C stands for? Cefaperazone, cefaperazone, cefaperazone. Can you tell me what is your chlorpropamide? It is nothing but your what group of drugs your chlorpropamide comes? Can you recall and tell me what group of drugs your chlorpropamide comes in your anti-diabetic? I've given this much clue for you. We have read in the anti-diabetic. So what is going to be your in the anti-diabetic where you are going to have chlorpropamide? Can you recall and tell me? Where you have chlorpropamide, they are the first sulfonyl ureas. Remember, sulfonyl ureas or the first generation we read chlorpropamide. Okay, so that is also going to cause disulfiram like reaction. Why you are discussing now? So remember, this procarbazine is going to have a disulfiram like reaction. So you are going to ask the patient to avoid alcohol while consuming procarbazine, and they are going to act as a MAO inhibitor. Which type of MAO is going to cause cheese reaction? Let me see who is going to answer. Which type of MAO causes cheese reaction? Is it A or is it B? Can someone put in the chat box? MAO inhibitor. Which MAO, when it gets inhibitor, leads to your cheese reaction? Which MAO? This also we discussed yesterday. Come on, guys. This also we discussed yesterday. MAO A inhibitor. Excellent. MAO B inhibitor, where will you see? Where will you see your MAO B inhibitor? Can you tell me in which condition you're going to see MAO B inhibitor? Okay, which drug? Which drug is going to be MAO B inhibitor? Can you tell a drug name? In the CNS we discussed. Can you recall and tell me? MAO B inhibitor. That is going to be your anti what drug? So what drug you're going to take? So do you remember? Gelin group of drugs. All your gelin group of drugs. Seligilin, rosagilin, safinamide. These are the drugs which are going to be your MAO-B inhibitor used as an anti-Parkinson drug. Excellent, excellent, Afif. Now we are going to move towards the next group of drug that is going to be your temozolomide. What happens is this temozolomide will be having excessive bioavailability. So we'll have a good bioavailability and they will also cross your blood-brain barrier. Therefore, the one of the trizine group of drug is going to be a temozolomide. This temozolomide is going to be used in drug glioblastoma multiforme. So glioblastoma multiforme. Have you all seen this movie Uttama Villan in Tamil? Kamala Hassan. So in that Uttam villain in the movie, Kamala Hassan will be having this disease called as glioblastoma multiforme or grade 3 astrocytoma. We call it as grade 3 astrocytoma or brain tumor. Okay, wow. So that's what he himself will be telling all these in the movie. If you have seen that movie scene, you will be having that recall. Okay, now moving on to discuss about, we have discussed the first compounds that are going to be your alkylating agent. We have completed alkylating agent. Can you recall and tell me what are the three groups we saw in alkylating agent? Just three group of drugs under alkylating agent. Can you recall and tell me? What are the three groups we saw under alkylating agent? Number one, it is going to be, number one, what we saw? The three groups. Number one, it is going to be nitrogen mustard. Okay, nitrogen mustard. What is the number two we saw? Nitrosuria. Nitrosuria is the number two. And what is the third drug? Trizines. Number two is going to be your trizines. So these are the three group of drugs which we saw in case of your alkylating agent. Now we are going to go for the platinum compound. What does your platinum compound do? Very simple. They are going to cause DNA changes. The platinum compounds, they are going to cause DNA changes. So what are the places where you're going to use this platinum compound? The first drug is going to be oxaliplatin. Okay, it's going to be oxaliplatin. So oxaliplatin is going to be utilized in your colorectal cancer. What is going to be colorectal cancer? So what is your drug of choice in colorectal cancer? Remember, Folfox. FOLFOX. This is going to be the regimen followed in your colorectal cancer. Till now, we saw two regimens. What is MOP regimen? Where will you use MOP regimen? Can someone put in the chat box? MOPP, MOP regimen. Where will you use MOP regimen? Where will you use MOP regimen? Can you put in the chat box? Come on, guys, be active. MOP regimen. Where will you use? Where will we have MOP regimen? MOP regimen. Hodgkin's lymphoma, excellent. What is the non-Hodgkin's lymphoma? What is the regimen followed in your non-Hodgkin's lymphoma? What is the regimen followed in your non-Hodgkin's lymphoma? CHOP regimen, excellent. The third regimen which we are going to see here is for colorectal cancer, that is your FOLFOX regimen. In that, what is FOL? FOL stands for folinic acid, F stands for 5-fluorouracil, and OX stands for oxaliplatin. Okay, if that is going to become refractory, refractory means if that is not working, then you go for FOLFIRI, FOLFIRI regimen. So we go for something called as FOLFIRI regimen. What is FOLFIRI regimen? Folinic acid, 5-fluorouracil, but instead of your oxaliplatin, when there is going to be a refraction to your oxaliplatin, then you go for IRI. IRI stands for irinotecan. Irinotecan. So IRI stands for irinotecan. What is irinotecan? It is a topoisomerase 1 inhibitor. Now, if you recall your cell cycle, which you have read in your biochemistry, you know that once there is going to be a starting of DNA replication, what happens? First, there is going to be a chopping up. So you're going to chop up. Then what happens? You have to remove the supercoil. So how will you remove your supercoil of your DNA? By using topoisomerase. Then what happens? Okay, topoisomerase is the one that is going to remove the DNA supercoil. Then what happens? There is going to be RNA polymerase that is going to come and sit in your DNA, and it is going to produce a mRNA coding. That is how your replication occurs. So now this supercoiling, DNA supercoiling remover is going to be a topoisomerase 1. So what is supercoiling? You have your DNA like this, isn't it? But if it is going to be like this, how your mRNA is formed? How can your RNA polymerase produce a mRNA? For that, what it does is, it is going to remove this coiling. How do it remove the coiling? By the use of topoisomerase 1. Now, what you're going to do? You're going to inhibit this topoisomerase 1. So, can you tell me which cycle of cell cycle it is going to inhibit? Where does your DNA replication occurs? Can you tell me at which phase of your cell cycle DNA replication occurs? Can you put in the chat box? We have seen G1 phase, S phase, G2 phase, M phase. In which phase you are going to have the DNA replication? It is going DNA replication occurs in the which phase? Can you put in the chat box? Yes, phase, excellent. So can you tell me that this oxaliplatin is going, this irinotecan is going to be very specific for your S phase. Okay, now what are the side effects? Diarrhea can be occurring. That is a side effect. Now coming to the second drug, that is going to be a cisplatin. Cisplatin is used in the small cell lung cancer. Small cell lung cancer, you are going to use in the non-small cell lung cancer and all your germ cell tumor. In germ cell tumor, what is going to be a regimen? Now we are going to see the fifth regimen of the day. That is going to be a BEP regimen. BEP regimen is used in the germ cell tumors. What are the germ cell tumor? Can you put in the chat box? What are the germ cell tumor you are going to find in ovarian cancer? Ovarian tumor, like germ cell tumors. Can you put in the chat box? What are the germ cell tumors? This we read. Granulosa cell tumor, very good. Second one. Granulosa cell tumor, very good. Second one. Can you tell me the second one? What is the second one? Only granulosa cell tumor. I was the one who taught you this in your pathology, isn't it? Can you tell me? Granulosa cell tumor, second one. Remember, Dinesh, granulosa cell tumor is not the germ cell tumor. Granulosa cell tumor, theca cell tumor, everyone are going to be sex cord tumors. Why? Because they are arising from your ovary. Okay, so what is your germ cell tumor? Okay, so you're going to have ovary like this. So inside your ovary, you're going to have your theca cell, granulosa cell. Inside the theca granulosa cell, you have something called as germ cells. The germ cell tumors are nothing but they are going to be exactly, now you are correct, Dinesh, it is dysgerminoma, York cell tumor, you have embryonal cancer, choriocarcinoma, teratoma. All these are going to be your germ cell tumor. York sac is a germ cell. So York sac tumor, you're going to have embryonal cell tumor, you're going to have teratoma, dysgerminoma, choriocarcinoma. These are the 5 germ cell tumors. What you told is a small sex cord tumors. Sex cord cell tumors, nothing but your granulosa cell tumor, Sertoli cell tumor, Leydig cell tumor, Theco cell tumor, fibroma. These are the 5 germ cells. These are the 5 sex cord tumor. Hope I am integrating with the pathology. Okay, you have to remember this. Okay, in your germ cell tumor, what is going to be a drug of choice? You go for bleomycin, etoposide, and platin group of drug. That is your cisplatin and everything. Etoposide is nothing but it is a topoisomerase 2 inhibitor. Now, first I told you is topoisomerase 1 inhibitor. What is a topoisomerase 1 inhibitor? Can you tell in the chat box? Just we saw topoisomerase 1 inhibitor. Can you give me the example of topoisomerase 1 inhibitor? Can you give me the example of topoisomerase 1 inhibitor? Can you give the example of topoisomerase 1 inhibitor? Just we discussed something, drug starts with I. Just I discussed the drug starts with I. Irinotecan. Remember, irinotecan is a drug that is going to be inhibiting your topoisomerase 1, which inhibits topoisomerase 2. Etoposide is going to inhibit topoisomerase 2, and you have this topoisomerase 2 is going to involve in the G2 phase. I told you topoisomerase 1 is involving in the S phase, whereas topoisomerase 2 is going to involve in the G2 phase. So this is going to cause leukomogenic, that is increase in the WBC production. Okay, now coming to, so what are the germ cell tumor drugs? It's going to be BEP. B stands for bleomycin, E stands for etoposide, and P stands for platin group of drugs, cisplatin, oxaloplatin, etc. Now talking about your etoposide. Etoposide is a topoisomerase 2 inhibitor. So they are going to cause leukomogenic. Okay, now what are the fourth point? So you use in the non-small cell carcinoma of lung. You use in small cell carcinoma of lung. You're going to use it in the germ cell tumor, in CA ovary, and your radiosensitive head and neck cancer. You're also going to use it in the radiosensitive head and neck cancer. So what are the side effects of your cisplatin? Remember, this cisplatin is highly hematogenic. What is that? It is going to cause vomiting. That is what you call it as a chemotherapy-induced nausea and vomiting. You call it as chemotherapy-induced nausea and vomiting. What is the drug of choice in chemotherapy-induced nausea and vomiting? It is going to be a palanosetron. Palanosetron, it is a drug of choice. What is palanosetron? It is 5-hydroxytryptamine 3 inhibitor. So now from the yesterday's class, first we discussed serotonin 1A, 1B, 1D, 1F. Okay, agonist. Then when we move on towards the next topic, we discussed about serotonin 2A receptors. Now I am going to discuss about serotonin 3 receptors. This serotonin 3 receptor is going to prevent from nausea and vomiting due to chemotherapy. So what is the drug you're going to target your 5-HT3? That is going to be a palanosetron. But what is the problem? You have a QT prolongation. So the problem is there is going to be a QT prolongation. If after 1 to 2 days, you can go for 5-HT3 inhibitor, that is going to be palanosetron. Along with it, you can go for dexamethasone and NK1 antagonist. Now coming to the cisplatin. So highly antigenic. What are the drugs which is going to cause highly nausea, vomiting? That is going to be a cisplatin, cyclophosphamide, doxorubicin. All three will be causing a nausea, chemotherapy-induced nausea and vomiting. Now nephrotoxicity. If there is going to be a nephrotoxicity, what is going to be the drug of choice? So nephrotoxicity due to anti-cancer drug. What will be your drug of choice? Remember, the drug of choice is going to be, what is going to be your drug of choice? The drug of choice is going to be amifostin. Drug of choice is amifostin, okay, which is going to protect your kidney. They protect your parotid gland from radiation. So remember, amifostin has two functions. It is going to protect your kidney from chemotherapeutic agent. It is going to protect your parotid gland from radiotherapy. Okay, then you have saline infusion. And this is going, and your mannitol diuretics. So you can go for amifostin, saline infusion, mannitol diuretics for nephrotoxicity induced by what? Induced by your chemotherapeutic agent. Now coming to discuss about your NK1 antagonist. You will be asking me what is NK1 antagonist. Yesterday itself we discussed this. Again, I'm just repeating the name. Aprepitant, and you have rolapitant, then you have netapitant. These are the NK1 antagonists. What are the NK1 antagonists? 3 drugs. Aprepitant, then you have rolapitant, then you have netapitant. Now coming to the third one, that is going to be ototoxicity. Fourth one, hypocalcemia. Fifth one, AML can develop. These are the drugs which we are going to give in case, which are the side effects of your cisplatin. These are the side effects of your platinum containing compound. Clear, right? Now we are going to move towards the third one, anti-tumor antibiotic. I told you in the first itself, you have only 3 compounds which are going to be non-cell cycle dependent. So what are the 3 compounds I told you? Number one, that is going to be your, can you repeat? What are the 3 compounds which are non-cell cycle dependent? Can you put in the chat box? What are the 3 compounds which are non-cell cycle dependent? Let me see. Alkylating agent, very good. Second group. platinum compound, third group, anti-tumor antibiotics. Now we are going to go into the third one, anti-tumor antibiotics. Remember, the first anti-tumor antibiotic which we are going to learn is going to be your anthracycline. Anthracycline, so they are going to cause DNA damage and they are going to cause topoisomerase 2 inhibitor. So what is the topoisomerase 2 inhibitor? Separate topoisomerase 2 inhibitor. Just your topoisomerase 2 inhibitor. Can you tell me which compound causes topoisomerase 2 inhibitor? Can you tell the drug which is going to be a topoisomerase 2 inhibitor? Can you tell me the drug which is going to cause topoisomerase 2 inhibitor? Can you put in the chat box? Topoisomerase 2 inhibitor. What is that drug? Very good. Etoposide. Can you tell me the topoisomerase 1 inhibitor? Can you tell me topoisomerase 1 inhibitor? I'll be repeating like this again and again because it has to get memorized in your mind. Very good. It is irinotecan. Very good. Now you have another topoisomerase 2 inhibitor, but not just topoisomerase 2. It is also going to cause DNA damage. What are those drugs? Anthracycline. Anthracycline. What are the drugs? Doxorubicin, danorubicin, mitoxantrone. Okay, first one is going to be a doxorubicin. They are used in the solid tumors like your lymphoma, like your CA breast, and donorubicin you use in the case of AML. Can you tell me the drug of choice in CLL? I discussed this. What is the drug of choice you use in CLL? CLL எந்த drug நம்ம யூஸ் பண்ணோம்னு I have discussed. CLL. Can you tell me what is the drug we used in CLL? Chronic lymphocytic leukemia. The one that comes under your first group of drugs. That is going to be your nitrogen mustard. Chlorambucil, excellent. So chlorambucil is going to be used in CLL. AML, you're going to use danorubicin. And you have the third one, mitoxantrone. It is used in multiple sclerosis. Okay, rapidly progressing multiple sclerosis. But in rapidly progressing multiple sclerosis, which is the most common drug used, dexrazoxone. So you will be using dexrazoxane. So you will be using dexazoxane. Okay, just add one more page. Just write a heading, multiple sclerosis. At this point itself, let me discuss about the multiple sclerosis and the drugs which you use for multiple sclerosis. Okay, for multiple sclerosis, the drugs which you are going to use are, do you know any other drug which we use in multiple sclerosis? Do you remember in any other place where we saw multiple sclerosis drugs? Do you remember? Can someone recall and tell me what are the other drugs which we saw in the multiple sclerosis? In multiple sclerosis, just try to recall and tell me. Multiple sclerosis, neurology, when we are discussing, I discuss certain drugs in multiple sclerosis which will be helpful in multiple sclerosis. Can someone recall and tell me? Can someone recall and tell me the drug? Let me see who is going to tell it. Let me see who is going to tell it. In an acute attack of multiple sclerosis, what is the drug you are going to give? Write it down, guys. So this separately, write it down. Okay, I will write it. I will just give you, write it down. Okay, so put the heading as multiple sclerosis. Okay, just put the FINGOMAD. Fingomad. Okay, F stands for your fingolimod. So it is a fingolimod. I'll tell you what is multiple sclerosis. Basically, in multiple sclerosis, there is no development of your myelin sheath. So there is going to be a failure in development of your myelin sheath, or there is an antibody that is going to act against your myelin sheath. Here what happens? There is antibody that is going to act against your myelin sheath. Because of this, there is going to be a demyelination. In multiple sclerosis, there is going to be demyelination. So what you are going to do is, you are going to give drugs that are going to help the patient from this neuronal transmission. It is going to help in neuronal transmission, prevent the antibody reaction against your myelin sheath. So number one is your fingomyelin. This fingomyeloid is nothing but fingolimod is nothing but they are going to be sphingosine phosphate inhibitor. This is going to prevent the release of lymphocyte into your brain. Number two, you go for interferon beta inhibitor. So interferon beta inhibitor, they will be decreasing the expression of inflammatory cells. Number three, you're going to write it down, natalizumab. What is natalizumab? Natalizumab is going to be alpha 4 beta 1 integrin. So this is going to prevent your lymphocyte entry into brain. This is going to be your natali. It's going to be natalizumab. What does G stands for? Remember, G stands for your glutamate. Okay, glutamate drug. What is glutamate drug? Glatinavir, glatinavir. Okay, glatinravir. Okay, acetate. So this is going to be the drug which is used. O stands for ocrelizumab. Don't go for the individual function and all. You are just going to mug up what are the drugs that are going to be used in the multiple sclerosis. No one is going to ask the mechanism of action. Sometimes what happens, they can ask you the drug of choice in multiple sclerosis. That is the reason why I am giving you this mnemonic and asking you to write. And what does M stands for? M stands for mitoxantron. They are going to inhibit the proliferation of B and T cell. Okay, and remember ocrelizumab. We will be discussing about this ocrelizumab soon. They are going to be acting as a anti-CD20. Anti-CD20 is going to act. Okay, now you're going to have this A. What does A stands for? Alan2-Zmab. Alan2-Zmab is going to act against anti-CD52. And last drug of choice, which is going to be your dalfampyridine. This is going to be a potassium channel blocker. Potassium channel blocker or your opener. Potassium channel opener. So the drug of choice apart from all these things is we can go for a steroid. Okay, you can go for a steroids. So these are the drug of choice. Take a screenshot. So this you have to memorize. You don't have a choice because you cannot go individually into each drug. Maximum I'll try to cover these drugs while I'm discussing about this anti-cancer drug for the next 1 hour. But what I will do is I'll just go in a very superficial manner. I won't discuss in detail because that is not necessary at your level. Okay. Have you taken a screenshot? Can you put a thumbs up after taking a screenshot? Can you take a screenshot and put a thumbs up so that I can move towards the next one? Can you put a thumbs up after taking a screenshot so that I can move towards the next one? Can you guys do it? Can you guys put a thumbs up, guys, please? So that I can continue after taking a screenshot. These are the drugs which you are going to use in multiple sclerosis. Fingomad. F stands for your fingolimod. I stands for your interferon beta inhibitor. N stands for natalizumab. G stands for glutamate. Then O stands for ocrelizumab. M stands for mitoxantron. And A stands for alan2-zimab. And D stands for dalfampyridine. These are the drug of choice for multiple sclerosis. Clear, right? Now you see here, what is the drug which among this, what is used here? So you have your mitoxantron. Mitoxantron is nothing but they are going to be from anthracycline group of drug. Anthracycline group of drugs. Can you go and check back here? So in anthracycline, you're going to have mitoxantron. Mitoxantron is used in the multiple sclerosis. It is used in the multiple sclerosis. That is the reason I was discussing all these things in detail. Now moving towards the side effect, bone marrow suppression, cardiomyopathy leading to congestive heart failure. In that case, okay, what is the drug you're going to give? You have to prevent. What is the drug you're going to prevent? The excessive action of anthracycline. You're going to give dexamethasone. Okay, dexamethasone. Okay, they are going to be iron chelator. What happens is this, when you're going to give in the patient with cardiomyopathy led due to the anti-tumor antibiotic, there is going to prevent the excessive action of anti-tumor antibiotic. What is the drug? So it is going to be your dexamethasone. So you have doxorubicin, danorubicin, mitoxantron, that are anthracycline. What are the antidote for anthracycline? That is going to be your dexamethasone. Clear, right? Then you're going to have a second group of drug that is going to be a bleomycin. This you would have commonly encountered. They are going to be G2 phase specific drug. Remember, so this is going to be G2 phase specific drug. They are used in the BEP germ cell. Do you remember what is BEP? Can you just expand that BEP regimen which you followed in your germ cell? What does B stands for? What does B stands for in germ cell? What does B stands for? Bleomycin. That is given already here. What does E stands for? What does E stands for? Come on, guys, put in the chat box. What does E stands for in your BEP regimen? BEP regimen. B stands for your bleomycin. Now you know it is going to be G2 phase specific drug. What does E stands for? What does your E stands for? Dinesh, Afif, and others. Can you put in the chat box? What does E stands for? Pradap is also there. What does E stands for? Just now I discussed. No. Come on. E stands for etoposide. Excellent. Etoposide are going to inhibit what phase? Etoposide inhibits what phase of your cell cycle? Etoposide inhibit what in your cell cycle? They are going to be either topoisomerase 1 or topoisomerase 2. Topoisomerase 2. It is not S phase. It is going to inhibit your G2 phase. It is going to be topoisomerase 2. Okay, topoisomerase 1 is going to be your irinotecan. They are going to inhibit your S phase. I want you to be very clear with that. Okay, your etoposide also going to inhibit G2 phase. Your bleomycin also going to inhibit G2 phase. And the third one is going to be a platin group of drugs. Do you remember what your platins inhibit? It is going to inhibit the DNA changes. It is going to cause DNA changes. So it is going to cause just DNA changes. Okay, clear, right? Now moving on to talk about the side effects of your bleomycin. So side effect, and it's also used in Hodgkin's lymphoma. What is the regimen you use in Hodgkin's lymphoma? What is the regimen you use in Hodgkin's lymphoma? Can you recall and tell me? It's going to be MOP regimen, MOPP. In this MOP regimen, okay, in this MOP regimen, what does MOPP stands for? In MOP regimen, miclor-ethamine, oncovin, prednisolone, procarbazine. In this also, you can also add bleomycin. So bleomycin is also used in case of your Hodgkin's lymphoma. Standard therapy is going to be a MOP regimen, but you can also go for the bleomycin. Clear, right? Next, you are going to go for the side effects. Flagellate skin pigmentation can occur and pulmonary fibrosis. So now you have to know what are the drugs that causes pulmonary fibrosis. Do you remember yesterday we were discussing about ergot derivative in your headache, migraine. So this ergot derivatives will be causing pulmonary fibrosis. Nitrofurantoin will be causing pulmonary fibrosis. Methotrexate causes pulmonary fibrosis. Bleomycin causes pulmonary fibrosis, and amiodarone causes pulmonary fibrosis. These are the drugs which causes pulmonary fibrosis. Write it down separately. The drugs which causes pulmonary fibrosis are amiodarone, bleomycin, methotrexate, nitrofurantoin, and ergot derivative. Okay, remember type what it does. What is the main action of all these drugs? So they are going to cause death of your type 1 pneumocyte, and they are going to cause proliferation of type 2 pneumocyte. So type 1 pneumocyte is going to be surfactant. சாவடிச்சிடுது. Type 2 pneumocytes என்ன பண்ணுது? It is going to cause proliferation. This leads to pulmonary fibrosis. Clear, right? Now you're going to have third group of drugs in the anti-tumor antibiotics. That is going to be a mitomycin C. So what is going to be the use of mitomycin C? Mitomycin C is used in case of a anal cancer, in case of bladder cancer, in case of intravesical, any organ cancer. We can use in the local conditions like your tracheal stenosis to act as an anti-fibrotic. So what are the side effects of it? Side effect is hemolytic uremic syndrome. Hemolytic uremic syndrome. What is hemolytic uremic syndrome? It is what it is. It is going to be, what is the hemolytic uremic syndrome? Where we read hemolysis. It is going to cause intravascular hemolysis. That is going to be a hemolytic uremic syndrome. Now coming to the actinomycin D. Actinomycin D is going to be the fourth drug which you are going to see under the heading anti-tumor antibiotic. So what are the drugs? So what it is going to do? It is going to be helpful in choriocarcinoma. So choriocarcinoma, you will use actinomycin D. But what is the drug of choice in choriocarcinoma? It is going to be methotrexate. Methotrexate is going to be drug of choice in case of choriocarcinoma. Finally, we are going to read the side effects of your actinomycin D. What are the side effects? Radiation recall syndrome. It is going to cause radiation recall syndrome. Now coming to the last one, that is going to be a M phase. So we are going to see about the M phase specific drugs. Are you all ready? I'll give you 1 minute break. So just kindly recall whatever we read till now. So whatever we read till now, we have read cell cycle non-specific drugs. So in cell cycle non-specific drug, we read 3 classification: alkylating agent, platinum compound, anti-tumor antibiotic. In platinum alkylating agent, you have nitrogen mustard, nitrogen ureas, and you're going to have triazines. So what is going to be under nitrogen mustard? Cyclophosphamide. Then you read ifosfamide, miclor-ethamine, chlorambucil, and miflon. Okay, melphalan. And you're going to have your nitrous ureas. You're going to have lomustine, carmustine. Then you're going to have the third group triazines. In that procarbazine, temozolomide. Okay, then we have platinum compounds. In the platinum compounds, we read oxaliplatin, cisplatin. We read about your cisplatin. Then we moved on to talk about the carboplatin. Then anti-tumor antibiotic, we had doxorubicin, danorubicin, mitoxantron. Then we read bleomycin, then mitomycin C, mitomycin D. Are you clear? Any doubt till now? If you have any doubt till now, post it in the chat box. I'll give you 1 minute time. Post it in the chat box, whatever doubt you have till now, because you're going to move towards the next one, M phase specific drug. So we're going to move towards M phase specific drug. So now we are going to specifically see each and every phase of your cell cycle. We are going to inhibit specific phase of your cell cycle. Targeted drug therapy. Can I move forward? If you have any doubt, if you don't have doubts, can you put it clear in the chat box or any thumbs up so that I can move towards the next one? A thumbs up. I'm not asking any fees, right? Just a thumbs up. Kindly put a thumbs up no in the chat box. Clear? Only Afif is there. Others, just a thumbs up. Only if you're going to put thumbs up, I'll be moving forward. Let me see. Afif, Everyday Max, Dinesh, others. Where is Amina, Manaf? Where is Gokul and Murugan? A thumbs up, please. Gokul, can you put a thumbs up? Shall I move forward? Okay, next I'm going to move towards the M phase inhibitors or M phase specific drugs. Okay, so first one, you have something called as your mitosis. Mitosis, there is something called as centromere. That centromere is going to attract the cell and they are going to cause a spindle formation. So from your centromere, there is going to be a movement to the periphery. So the stretch movement that is called as your spindle formation. Either what you can do is you can inhibit the formation of spindle, number one, or what you can do is you can actually break down the spindle after formation. That means either you can prevent the formation of spindle by inhibiting the polymerization of microtubules, or what you can do is you can, after the formation of your spindles, what you can do, you can break down those spindles. That is called as depolymerization of mitotic tubules. So polymerization of mitotic tubules inhibit pandrathu Vinca alkaloids. It's not Vica alkaloids, I'm sorry. It is Vinca alkaloids. And what is the drug that is going to cause spindle dissolution? That is going to be your taxanes. So we are going to see two group of drugs. Number one, Vinca alkaloids. The first drug in your Vinca alkaloids is going to be your vincristin. Remember, vincristin is going to be your bone marrow sparing drug. Remember, vincristin is going to be a bone marrow sparing drug. What are the side effects you are going to cause? There is going to be neuropathic pain. The patient will be having a SIADH. What is SIADH? It is nothing but syndrome of inappropriate antidiuretic hormone. There is excessive production of antidiuretic hormone like substances. So that is going to be there in your vincristin as well as in your cyclophosphamide. Also. Now, where all you're going to use? Do you remember CHOP regimen, which is used in non-Hodgkin's lymphoma, or MOP regimen used in your Hodgkin's lymphoma? You have the vincristin and your vinblastin, all these group of drugs. So can you expand? So what happens in your MOP regimen or your CHOP regimen? You're going to have O. O stands for oncovin. This oncovin is nothing but it is going to denote your vincristin. You're going to denote your Vinca alkaloids. So what are the drugs under Vinca alkaloids? You have vincristin and your vinblastin. Clear, right? So vincristin is used in the CHOP regimen. Vincristin is used in your MOP regimen. And you're going to also use in ALL. In your ALL. In ALL, what happens is when you're going to add vincristin, along with that, when you're going to have your prednisolone. So and your methotrexate. So vincristin, prednisolone, methotrexate. What happens? It is going to inhibit the conversion of asparagine to aspartic acid. So it is going to cause conversion of asparagine to aspartic acid. Clear, right? Now can you tell me what is the drug used in your CLL? Come on, fast. What is the drug you are going to use in CLL? What is the drug you are going to use in CLL? Can you post in the chat box? The drug used in CLL? Chronic lymphocytic leukemia. The drug we are going to use in the chronic lymphocytic leukemia, chlorambucil. Excellent. What is the drug you are going to use in the CAML? What is the drug you are going to use in AML? Can you put in the chat box the drug which we use in the AML? Okay, in the drug which we use in AML. Can you tell me? What is the drug we use in AML? Anti-tumor antibiotics. Under the heading anti-tumor antibiotics, we saw a drug used in the AML. Can you put in the chat box? Can you put in the chat box, guys? Come on. The drug used in AML. What is the drug we are going to use in AML? Can you put in the chat box? Danorubicin, excellent. That is the second drug. Now we are going to move towards the third drug. That is going to be the drug for your ALL. ALL, you are going to use vincristine, methotrexate, and prednisolone. VMP. Okay, VPM. Remember VPM. Okay, Vice Principal of Medical College, VPM. So vincristine, prednisolone, methotrexate. These are the drugs used in the ALL. Now moving on to talk about your vinblastine. Vinblastine, vincristine, rendume same da. But in your vincristine, what is the problem? You had a neuropathic pain. You are going to have a SIADH. But that too will not be present in your vinblastine. But your vinblastine causes bone marrow suppression. Now that's all about your vinca alkaloids, which is going to prevent polymerization or spindle formation. The one which is going to destroy your spindles, that is going to be your taxans. So in taxans, the first one is going to be your paclitaxel. Paclitaxel, it is obtained from the taxus plant. That is why you give the name taxanes. Paclitaxel. So they are going to cause bone marrow suppression and they will cause peripheral neuropathy. And second one is going to be, so this all about your taxanes. Now we have completed two drugs. So in your M phase specific inhibitors, we completed vinca alkaloids. We completed to talk about your taxanes. Now the third drug which is going to inhibit your M phase of your cell cycle is going to be ixabilone. They are just like your taxane. The mechanism is just like your taxanes, and you have something called as ercibulin. Okay, ercibulin is a drug which is your mitotic inhibitor. How to remember this ercibulin? I'll tell you. ER receptor, where will you find this ER receptor? ER, ER2 receptor, where you will find in your breast cancer. So your ercibulin is also used in which condition? Breast cancer. So your ixabepilone and your ercibulin both are going to be used in which condition? CA breast. Now coming to the next drug, that is going to be your estramustin. So what is the drug that ended with mustin? Can you tell me the drug that ended with mustin? Which group ended with mustin? Already the one which we saw. Which group of drugs ended with mustin? In the drugs we saw already in your anti-neoplastic drugs. Which drug ended with mustin? Can you put in the chat box? Which drug ended with the terminology mustin? MUSTIN. Can you tell me? Excellent. Nitrous urea. So nitrous urea is a low mustin, carmustin is there. But this estramustin is not going to be your nitrous urea group of drugs. They are going to be very important. They are going to be a cell cycle specific inhibitor. In which phase? Mitotic phase, M phase. Okay, remember. So this is going to be an important drug in your CA prostate. What is the main action? It is going to cause excessive estrogenic activity. Therefore, the side effect which is going to be causing us gynecomastia. Now remember, M phase inhibitors, we have read three drugs. What are the three drugs? Number one, we read two yield starter drug, estramustin, ercibulin. Okay, then we saw one starting with I, ixabepilone. We saw one starting with I, that is ixabepilone. Then we had taxane group of drugs. Then we have I. I stands for your taxane group of drugs. Then we had something called as your vinca alkaloids. Okay, so what are the five drugs which we read under the heading of M phase inhibitors? Number one, vinca alkaloids. Number two, taxane group of drugs. Number three, ixabepilone. Number four, ercibulin. Number five, estramustin. Now we are going to move towards the S phase specific inhibitors. So now we have completed M phase specific inhibitor. Now we are going to move towards S phase specific inhibitor. S phase DNA synthesis, guys. Very easy. DNA synthesis, the S phase. Can you tell me the drug which we used already that is going to cause a S phase inhibition? Can you name a drug which we saw already that is going to inhibit your S phase? Can you name the drug which is going to cause S phase inhibition? Can you name the drug which causes S phase inhibition? Irinotecan, excellent. What it is going to inhibit? Topoisomerase. topoisomerase 1 inhibitor. It is going to be a topoisomerase 1 inhibitor. See here, you are going to now see certain S space. So what it is? So for DNA synthesis to happen, you need basic material for your DNA, that is purine and pyrimidine. When you are going to give a purine analog, instead of original purine, if you are going to give an analog, purine analog, what happens? This purine analog, when you're going to give, so the example, theoguanine. So when I'm going to give you a drug called as theoguanine, what happens? The patient, instead of taking the DNA synthesis, guanine edukama, theoguanine is going to be taken for DNA synthesis. But will the theoguanine fit into a DNA? No. Therefore, there is no DNA synthesis at all. So this is how you are going to inhibit your DNA synthesis by giving purine analog. This is a very important one for the treatment of leukemia. Very okay. So azothioprine, if you are going to give, azothioprine is going to go into your liver and it is going to get converted to 6-mercaptopurine. This 6-mercaptopurine, what happens? They are going to be under xanthine oxidase. So under xanthine oxidase, they are going to get converted into a mercaptopurine is going to get converted into a purine compound. This purine is going to be further can be broken down into uric acid. It can be broken down into uric acid. So when you are going to give excessive azothioprine, what happens? It is going to lead to excessive uric acid level. So when you're going to give more azothioprine, that leads to excessive uric acid, and excessive uric acid leads to a condition called as gout. So what is the side effect of purine analog? That is your azothioprine. The side effect of purine analog is going to be your gout. So what do you do is you're going to add a allopurinol. So what you will think, okay, I will add allopurinol. Now patient will be, you're going to give allopurinol for the patient. Allopurinol is going to inhibit what? Xanthine oxidase. So it's going to inhibit xanthine oxidase. Now when it is going to inhibit xanthine oxidase, what happens is there is going to be excess amount of 6-mercaptopurine getting accumulated in your liver. When there is more amount of 6-mercaptopurine accumulated in your liver, what happens? It leads to hepatotoxicity. So the drug example for your purine analog is going to be two drugs. Number one, you're going to have azothioprine. Azothioprine. Number two is going to be your theoguanine. But why theoguanine is going to be important drug which is going to be used as a drug of choice? Because they don't have a metabolism like this with the xanthine oxidase. But what happens? This azothioprine gets converted into a 6-mercaptopurine. This 6-mercaptopurine, what happens? It is going to cause toxicity when you're going to add up allopurinol. Because what you will be thinking is you wanted to remove the uric acid from the body. So when you're going to say increase in uric acid, what you will do? You will give a allopurinol. But this will further cause liver toxicity. So you should not give allopurinol in the patient. Okay. So where will you use azothioprine? Azothioprine is used in the case of treatment of leukemia in a million cell die. So when there is a million cell going to die, I think I told you this in the pathology when I was discussing. See, when you are going to give a azothioprine in a patient of Burkitt's lymphoma, for example, let's consider Burkitt's lymphoma. What happens suddenly is your Burkitt's lymphoma, immediately when you're going to give a chemotherapy agent, what happens? All the cells will be starting to die. So when all cells starts to die, what happens? They are going to be phagocytosed by the, or it is going to cause phagocytosis by all your dead cell is going to be phagocytosed by your macrophages. So that is why you have the starry sky appearance. Do you remember? You have something called a starry sky appearance. Do you remember? You would have read in your Burkitt's lymphoma. Why that starry sky appearance is there? See, you're going to have a you're going to have something cell like this. So in this, what happens? You will be having in this, what happens is you will be having your all your macrophages. They are going to engulf. So what your macrophages going to do? Your macrophages basically it is going to engulf. Okay, this is your this is your slide. In this, what happens? Your macrophages is going to engulf all the tumor cells. They are going to engulf all the tumor cells which they die. So how it looks like? It is going to be looking like a starry sky appearance. So sutti dark, nadula or star இருக்கிற மாதிரி. That is why you call it a starry sky appearance. This is a very typical feature of Burkitt's lymphoma. Why? Because of the tumor lysis syndrome. So in case of tumor lysis syndrome, so allopurinol is used when you are going to have a decrease in the dose of 6-mercaptopurine azothioprine. So when you are going to give a decreased drug of azothioprine and mercaptopurine, then what you can give? You can give allopurinol, because allopurinol will be helping you to remove the uric acid. But always be careful with the dosage of allopurinol and 6-mercaptopurine. Are you clear with this? Now we are going to move. What are the other drugs? You have fludarabine. Fludarabine is another drug which is used in the chronic lymphocytic leukemia. Can you tell me what is the drug used in chronic lymphocytic leukemia? Already we have learned what is the drug used in chronic lymphocytic leukemia. Don't feel shy or don't feel tired in typing in the chat box. That is how you're going to remember while you are attending your exam. What are the drugs that are used for your chronic lymphocytic leukemia? Number one, we already read one drug. What is the drug named? What is the drug named? Chlorambucil. Am I right? Am I right or wrong? Am I right or wrong? Chlorambucil is the drug which is used for CLL. Okay, now you have another drug that is called as your fludarabine. Fludarabine is also going to be a drug of choice in case of your chronic lymphocytic leukemia. And you have your cladarabine. Cladarabine is used in hairy cell leukemia. Okay, cladarabine, hairy cell leukemia, fludarabine used in the chronic lymphocytic leukemia. Now you have the B group that is going to be your pyrimidine analog. So till now what we saw is a purine analog. Now you have azothioprine, you have your fludarabine, you have clodarabine, and you have thioguanine. Now we are going to have a pyrimidine analog. What are the pyrimidine analog? You're going to have 5-fluorouracil. This 5-fluorouracil is a drug of choice. Do you remember? So we have this Folfox and your Folferry. Do you remember? Folfox, right? And your Folferry. Okay, Folfox and Folferry. Do you remember where you have this Folfox and Folferry? In which cancer? In which cancer you have this Folfox regimen and Folferry regimen? Folferry regimen. Where will you have? Put in the chat box. Come on. Folfox regimen and Folferry regimen is used in which cancer? In which cancer? Come on, guys. Colorectal cancer or colon cancer. So, அங்க நம்ம என்ன பார்த்தோம்? Folinic acid, 5-fluorouracil, oxaliplatin or 5-fluorouracil, 5-fluorouracil, folinic acid and your irinotecan. So, inge what is the drug which you are using? That is your 5-fluorouracil. It is used in the anal cancer. So, it's pro drug. So, they are not given directly as a 5-fluorouracil. Instead, you given as a drug called as capacitabine. Okay, capacitabine is a pro drug for your 5-fluorouracil. Capacitabine is the one which we are giving for the patient. They convert into a 5-fluorouracil. What are the side effects? You are going to have hand-foot syndrome. Now let's see what are the drugs that causes hand-foot syndrome. You have 5-fluorouracil, capacitabine, doxorubicin, cytarabine, sorafenib, sunitinib. Sorafenib, sunitinib. All these drugs will be causing hand-foot syndrome. Clear, right? Now coming to the next one, cytosine arabinoidase. So cytosine arabinosin. So they are nothing but they are given as cytorabine. So first one we saw as a capacitabine. Second one cytorabine. This cytorabine is a drug of choice in case of AML. Can you tell me what is the drug already we have given for AML? Can you tell me what is the drug we gave for AML? The other drug which we have already given for AML. We have told as drug of choice for AML. Can you tell me? Can you tell me what is the drug we have given for AML? The drug we have given for AML, can you tell me? Danorubicin. Now we are going to go for the second drug that is going to be cytosine arabinosin, or we can call it as a cytarabine. So remember, you have your M0 to M7 phase. So M0 to M7, the drug of choice is cytorabine and your danorubicin. So this is going to be the drug of choice. What are the side effects you're going to have? Cerebellar effect like your ataxia, nystagmus, diplopia. If at all you're going to have M3. What is M3? Promyelocytic leukemia. If it is a promyelocytic leukemia, you're going to give all trans retinoic acid, ATRA. What are the side effects of all trans retinoic acid? They can lead to pleural effusion and pericardial effusion. They can cause pleural effusion and pericardial effusion. Now moving towards the third group of drug, that is going to be your dihydrofolate reductase inhibitor. The third group of drug is going to be dihydrofolate reductase inhibitor. There are two drugs in dihydrofolate reductase inhibitor. One is going to be a methotrexate and one is going to be a pimatrexate. Okay, methotrexate, it is going to inhibit just your dihydrofolate reductase. Okay, but your pimatrexate is going to inhibit dihydrofolate reductase thymidylate synthase. Along with thymidylate synthase is also going to get inhibited. So along with your dihydrofolate reductase, it is also going to inhibit. It is also going to inhibit what? It is going to inhibit your thymidylate synthase. Take a fresh page and just try to copy down this reaction. Try to copy down this reaction. Just hold on. Yeah. So I'll just draw this reaction, try to copy down this reaction. Okay. What happens basically is usually your serine, okay, your serine will be converted to glycine. So for the serine to convert into glycine, what you need? You need M. Okay. So methyl hydrofolate. Okay. Methyl hydrofolate. So this methyl hydrofolate is going to be converted to FH4. So in the methyl group, from your methyl hydrofolate is going to get, it's going to be given to the, it is going to be given to the diuridyl monophosphate is going to get converted into diuridyl monophosphate is going to get converted into a, okay, this methyl group is going to be taken by your dimethyl, okay, it is going to be taken up by your DTMP. So dimethyl diuracyl monophosphate, this diuracyl monophosphate is going to get converted into a dithiamine monophosphate. For this reaction, you need a methyl group transfer. So your diuracyl monophosphate has to get converted into a dithiamine monophosphate. For that, you need a methyl group from your methyl folate to your folate. Okay, tetrafolate. This is going to be a tetrahydrofolate. So there's going to be a methyl tetrahydrofolate, which is going to get converted back into a tetrahydrofolate, which is going to get converted back into a tetrahydrofolate. Now, in the methyl group, there is a giving up of H2, there is going to be giving up of carbon. Carbon compound and H2 compound is given outside. For this process, this you are going to have dihydrofolate reductase. This enzyme is required for converting your methyl tetrahydrofolate to tetrahydrofolate. Similarly, for conversion of your diuracyl monophosphate so to thiamine monophosphate, for this conversion you require thymidylate synthase enzyme. So we are going to target two drugs. We are going to target two drugs that is going to inhibit either your dihydrofolate reductase, that is going to be your methotrexate, whereas the one that is going to inhibit both your dihydrofolate reductase as well as thymidylate synthase. So what is the drug you are going to give? You are going to give a p-metrexol. So you are going to give p-metrexad, that is going to inhibit both this one as well as your this one. Did you copy down? Can you understand the mechanism of action of your methotrexate and pemetrexad? Methotrexate and pemetrexad. So one is going to inhibit only your dihydroxy, you're going to inhibit only your dihydrofolate reductase inhibitor, whereas the other one that is going to inhibit your dihydroxyfolate, okay, reductase enzyme as well as your thymidylate synthase enzyme. Okay, so that is that you should understand. Okay. So for this, okay, if the patient is going to have this one, so what happens is here you also require vitamin B12. Okay, vitamin B12 is required here. You need vitamin B9. This is nothing but your vitamin B9, isn't it? So you need vitamin B12 for this thymidylate synthase. You need vitamin B9 for conversion of dihydrofolate reductase. Now, if you are going to give a, okay, if you're going to give a methotrexate, what is the drug you're going to add on with it? You're going to just add folinic acid. That is going to be vitamin B9. So only vitamin B9 has to be added whenever you're going to give methotrexate drug for the patient. So what is the folinic acid? That is going to be a leucovorin. So leucovorin is going to be a folinic acid. So always supplement with the leucovorin whenever you're going to give a methotrexate for a patient. Whereas if you're going to give a patient having a pemetrexad, so you're going to supplement vitamin B12 as well as folic acid, because vitamin B12 is also going to be inhibited. Vitamin B12 synthesis is also going to be inhibited. Vitamin B9 is also going to be a deficient here because of inhibition of this process. Therefore, you're going to supplement with vitamin B12 as well as vitamin B9. So clear, guys? This is how you're going to understand why you're giving vitamin B9, vitamin B12 in your pemetrexad drug, whereas along with methotrexate, why you're giving just your vitamin B9. Clear, right? Now, high dose, you have your two things. High dose methotrexate, low dose methotrexate. When you will be giving a high dose methotrexate, when you will be giving low dose methotrexate. High dose methotrexate is given in the, okay, you are going to remember it like COLA, cola or coal. You can remember either cola or coal. So cola, you're going to use in high dose methotrexate. So what is cola? C stands for your carcinoma breast. C stands for your choriocarcinoma. O stands for osteosarcoma. L stands for lymphoma. A stands for ALL. What are the other drugs which we used already in ALL? Can you recall and tell me the drug which we saw in ALL? Did we see any drug in ALL till now? No. Okay. So till now we saw CML. We have saw AML, we have saw CLL, Okay, now we have seen a drug for ALL. Clear, right? So CLL drug is chlorambucil. CLL drug is chlorambucil. For your AML, we gave danorubicin. For AML, we gave danorubicin. For AML, we gave danorubicin. And then we have this AML. Again, we give cytorubicin. So we give cytorubicin, cytoarabinosin. Sorry, cytoarabin. Cytoarabin is given in AML. And for ALL, we again went for vincristine. Vincristine and prednisolone is given for ALL. Now we are giving for your another drug for ALL, that is going to be a methotrexate. Okay, there itself I told you in methotrexate itself. What I told you, you are going to give vincristine, methotrexate and methylprednisolone. These are the three combination given in ALL. Write it down. We are going to give methotrexate, we are going to give vincristine, and third drug which we are giving is going to be your prednisolone. So these are the three drug which we are giving in case of your ALL. Then comes your low dose methotrexate. So where all you are going to give low dose methotrexate. Remember, low dose methotrexate drug of choice is going to be in your rheumatoid arthritis. In rheumatoid arthritis, 7.5 to 25 mg per week. You are going to give methotrexate. Apart from that, you have psoriasis, you have your MTP. In MTP, we are going to use methotrexate sometime. Ectopic pregnancy, we will be using methotrexate. Clear, right? And your Parkinson brain disease. Even in Parkinson's disease, we will be using this methotrexate to some extent at severe diseases. Then you're going to have side effects of your methotrexate. Remember, the side effects of methotrexate are bone marrow suppression, pulmonary fibrosis. Can you tell me what are the drugs that causes pulmonary fibrosis? Already we discussed. What are the drugs that causes pulmonary fibrosis? Can you put in the chat box one by one? What are the drugs that caused pulmonary fibrosis? We saw 5 drugs. We saw 5 drugs. Can you recall and tell me those 5 drugs? Can you recall and tell me those 5 drugs? What are the 5 drugs that causes pulmonary fibrosis? Put it in the chat box. Let me see. The one starts with A. What is the drug that starts with A? Not a okay. Alkylating agent. Varadhupa. Maximum alkylating agent varadu. First one starts with A. Is not alkylating agent, Afif. You can tell, but what are the 5 important drugs? If I ask you, you're going to tell me the 5 important one. Okay, it will be causing, if you're going to ask me about your alkylating agent, they are going to cause teratogenicity, leukomogenic, and your sterility, alopecia, marrow failure, pulmonary fibrosis. Yes, of course, I will accept. Okay, you can have this alkylating agent, but top 5, if I ask you, last I can add it as an alkylating agent. Last drug, I can add this alkylating agent. But what are the first 5 drugs? Alkylating agent, I can add it as a last drug. What are the first 5 agents? Can you recall and tell me what are the 5 drugs which is going to be there? Alkylating agent, I accepted what Afif told. What are the other 5 drugs which is going to cause pulmonary fibrosis? Which is going to cause pulmonary fibrosis? This I told you separately. I asked you to note it down. I hope so. If you have noted down, you will be answering right now. What are the drugs? What are the drugs? Kindly write it down at least now. A stands for amiodarone, and also you can add alkylating agent. B stands for bleomycin. Very good. B stands for bleomycin, very good, Afif and Dinesh. And M stands for methotrexate, and you're going to have nitrofurantoin, and your ergot alkaloid. So if they are going to ask in your exam, probably the best 5 is going to be these 5 drugs. Pulmonary fibrosis also occurs in alkylating agent, but alkylating agent on the pulmonary fibrosis is the last step. Okay, first side effect will not be a pulmonary fibrosis. So these 5 drugs, amiodarone, bleomycin, methotrexate, nitrofurantoin, ergot alkaloid. These are the 5 drugs that are going to cause pulmonary fibrosis. Hope you are clear with this, right? You have any doubt? Hope you are clear with this, right? Next, it can cause liver failure or liver fibrosis. Overdose, if there is there, it's going to be acidic drug. So what will be the drug you're going to give to break down the acidic drug? NaHCO3. Similarly, glucocapsidase. Glucocapsidase will be breaking down your methotrexate and causes methotrexate toxicity in case of a renal failure. Clear, right? With this, we are completing the first part of anti-tumor drugs, and the last part of anti-tumor drugs we are going to see next. So what is the last part of anti-tumor drugs? That is going to be your So now what we have seen is, we have seen the non-targeted cells. We have seen non-targeted cells. Now non-targeted cells we divide into two. One is a cell cycle specific drugs, and we have seen cell cycle non-specific drug. Cell cycle non-specific drug. So what are the drugs which we saw in the M phase? Can you put in the chat box? What are the drugs we saw in the M phase? 5 drugs. 5 drugs which we saw in the M phase. Can you put in the chat box? 5 cells which we saw in the M phase. 5 drugs. 5 group of drugs we saw in the M phase. Can you put in the chat box? Number 1. Come on, come on. You have to complete in next 15 to 20 minutes. Vinca alkaloid, excellent. Second one. Taxanes. Second one is a taxanes, excellent. Third one. What is the third drug which we saw under the heading? Under the heading M phase inhibitors. What is the third drug? I la start agradhu. What is the I? The one that starts in I. Ixabepilone. Okay. What is the one starts with E? What are the 2 drugs that starts with E? Can you recall and tell me 2 drugs that starts with E? You have your estramustin and you have your ercibulin. Yes, okay, estramustin and you're going to have your ercibulin. Very good. And what are the drugs that starts with your S phase? What are the drugs that starts with your S phase? Number 1, purine analog. We had 6-mercaptopurine, azothioprine. And then we had then we have your other drug, thioguanine. Now, and what are the 2 other drugs? Fludarabine and claudarabine. Okay, then we have pyrimidine agonist. You're going to have 5-fluorouracil. Then we have cytarabine. Then we have the third group, that is going to be a dihydrofolate reductase, methotrexate, and we have also seen the next one, pemetrexed. Okay, pemetrexed. So with this, we are completing the first part of anti-cancer drug. The second part is going to be targeted anti-cancer cells. How we are going to target just the anti-cancer cell, either by monoclonal antibody or you can go for kinase inhibitor. Number 1, monoclonal antibody. Remember, monoclonal antibody against your CD20. Can you recall and tell me what is the drug which we saw while we were discussing? I was telling you, right, against CD20, the drug that acts against CD20. Where I told you the drug that is going to act against CD20. I told you some drug. Do you remember? The drug that is going to act against CD20, I told you. The drug that is going to act against CD20, anti-CD20. I told you this specifically. Can you recall and tell me where I told you? Anti-CD20 drug. Where I told you anti-CD20 drug. Can you recall and tell me? Anti-CD20 drug, I told you. Where did I tell this anti-CD20 drug? Can you recall and tell me? Where I told you this anti-CD20 drug? I'll give you time, don't worry. Just try to recall and tell me. I just want you all to recall here itself. Non-Hodgkin's lymphoma, excellent. Non-Hodgkin's lymphoma, நம்ம என்ன பார்த்தோம்? Non-Hodgkin's lymphoma, okay. In non-Hodgkin's lymphoma, what is the thing we saw? Under non-Hodgkin's lymphoma, what we saw? We had cyclophosphamide, we have hydroxydoxorubicin, oncovin and prednisolone. This is what we saw under non-Hodgkin's lymphoma. But where we specifically saw CD20, where we specifically talked about the CD20, where we specifically talked about the CD20. Can you recall and tell me? Multiple myeloma onu paathom. Now orka? Are you all recalling that? We have discussed about something called as multiple myeloma. In that multiple myeloma drugs, what is the mnemonic which we remember? Fingo. So what is the mnemonic which we remember? Fingomad. Among that Fingomad, do you remember O stands for? O stands for ocrelizumab. Ocrelizumab. Do you remember? Ocrelizumab comes under Fingomad. Fingomad, O stands for your ocrelizumab. That is going to be a drug of choice in case of multiple sclerosis. Do you remember? Maintenance drug of your multiple sclerosis. So that is nothing but that comes under your monoclonal antibody. That is going to be a CD20. The drugs that are going to act against CD20. So what are the drugs? Remember, RIT2 is too much. RIT2 is too much. Remember like this. RIT2 is too much. So R stands for rituximab. Rituximab, you are going to remember. So CD20, what is the marker? What is the CD20 is a marker of which cell? B cell or T cell? At least tell that. CD20 is a marker of B cell or T cell. Can you tell me in the chat box? CD20 is a marker of B cell or T cell. Very good. It's a B cell. I discussed this in hematology. So it is going to be a B cell, right? So you're going to act against what type of B? You're going to act against your lymphocytes. So that is why this is going to be against your non-Hodgkin lymphomas, CLL, chronic lymphocytic lymphomas. So it's going to act against your CLL, and it is also going to be having a use in your rheumatoid arthritis, SLE, thrombotic thrombocytopenic purpura, and your multiple sclerosis. Now coming to the IS, IS stands for Ibritumab. Ibritumab. So that is going to be your I stands for Ibritumab. Okay. So this is going to be your IS, and T stands for Tocilizumab. What is this Ibritumab and Tocilizumab? They are going to be acting against the non-Hodgkin's lymphoma. Here I will tell you one example. I starts with I, right? So here the antibody that is going to be there is going to be a radioisotope conjugate. What radioisotope? It is going to be your yttrium. Do you remember? Have you heard about this yttrium? Yttrium is going to be a metal. Okay, so it's going to be like your iodine. It's a radioactive substance. Yttrium 90 is used as a antibody conjugate in your Ibritumab and in your Tocilizumab. What is the drug you're going to give? In Tocilizumab, the one which you're going to give is iodine 131. In Tocilizumab, you're going to give iodine 131. In your Ibritumab, you're going to give iodine. You're going to give yttrium 90. So everything is going to be ending with Tumomab. So mab is going to be monoclonal antibody. You are going to project. You are going to give a radioisotope against. You are going to give a radioisotope against your tumor. That is why we call it as Ibritumab and Tocilizumab. These are the two drugs. So rituximab, Ibritumab, Tocilizumab, and what does O stands for? O stands for Ofatumumab, and other O stands for obinutuzumab. You have obinutuzumab, and what is another O? Ocrelizumab. Remember rituximab, Ibritumumab, and you have Tocilizumab, and you have Ofatumumab. Tumu is nothing but a tumor. So mab is a monoclonal antibody. It is going to be Ofatumumab. Okay, and you're going to have obinutuzumab and ocrelizumab. Okay, then finally much. M stands for multiple myeloma. Remember, in multiple myeloma, you're going to have two types. So it's going to be, there are two types of multiple myeloma basically. What are the two types of multiple myeloma? Listen carefully. You're going to have relapsing and remitting type. What is RRMS? It is nothing but your relapsing and remitting type. Of multiple sclerosis, whereas PPMS is nothing but primary progressive multiple sclerosis. In primary progressive multiple sclerosis, the drug of choice is going to be ocrelizumab. Okay, but if it is going to be RRMS, relapsing and remitting, do you remember what is the second one of your FINGO? I stands for interferon beta. So you are going to give interferon beta subcutaneously. That is the drug of choice. Glatimer acetate can also be given. Fingolimab can be given, and natalizumab can be given. Natalizumab is going to be anti-integrin. I explained you all these things. So always remember this anti-integrin. What it will do is, it is going to increase the promyelocytic leukemia. Promyelocytic leukemia cause panachna side effect. What happens? You know that promyelocyte is going to be helping in inclusion body formation. Therefore, they are going to cause antigen antibody reaction whenever there is going to be JC virus. So when the patient is going to be affected with JC virus, there is going to be antigen antibody reaction. So what you are going to do is, you are going to check whether JC virus is there. Only after screening, you are going to give natalizumab. Clear, right? Then you have something called as brentuximab. Brentuximab. So this is going to be a CD30 inhibitor. So this is present in Hodgkin's lymphoma. And gemtuxumab. Gemtuxumab is given in CD33 inhibitor in your AML. And your ozagamicin. It is an antibody against conjugate toxin. Remember, it is an antibody acting against conjugate toxin. Then you're going to alemtuzumab. Alemtuzumab is CD50 inhibitor, CLL. Clear? Now from first, what we are seeing? CD20 inhibitors நம்ம பார்த்தோம். Next CD30 inhibitor, then CD33 inhibitor, then we saw CD50 inhibitor. Have you copied down? Have you copied down? I'll be asking questions from this at the end of the session. Have you copied down? Yes, right. So in a tumor, what is the other problem you have? One is growth of this, when there is going to be growth of the cell. Growth of the cell, anti-tumors, cell cycle inhibit pandrom. We are going to target the cluster differentiation cells. All this we done. What is the other problem we have? We have something called as neovascularization. You would have read in the pathology, right? What is going to be the process of neoplasia? They have given some 7 steps of neoplasia. So hope you have read that. So on the 7 steps, one enna neovascularization. So the neovascularization of you are going to inhibit is by creating an antibody against your vascular endothelial growth factor. So this vascular endothelial growth factor, when it is going to be stimulated, what happens? So whenever there is going to be a tumor, the tumor is going to require what? The tumor is going to require oxygen. So for the oxygen requirement, for constant supply of oxygen to the tumor cells, what it does, it is good. There is going to be hypoxia. So hypoxia and tumor cells will be stimulating your vascular endothelial growth factor. This vascular endothelial growth factor is going to go and sit on the vascular endothelial growth factor receptor. When it is going to sit in the vascular endothelial growth factor receptor, there is a production of tyrosine kinase. When the tyrosine kinase is produced, what happens? It is going to cause stimulation for the production of new blood vessels. So what you are going to do, either you can inhibit the VEGF receptor, that is going to be vascular epithelial growth factor receptor, or what you can do is you can inhibit your vascular endothelial growth factor itself, or what you can do, you can inhibit this tyrosine kinase. 3 places you can inhibit basically. Number 1, vascular endothelial growth factor receptor, or you can go for vascular endothelial growth factor itself, or you can go for tyrosine kinase inhibitor. The first one is vascular endothelial growth factor receptor, which is going to inhibit your receptor. That is going to be a ramucirumab. 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 That is a drug which is going to inhibit your vascular endothelial growth factor receptor. Next comes your bevacizumab and ranibizumab. Bevacizumab and ranibizumab. These 2 drugs are going to inhibit vascular endothelial growth factor itself. Remember, bevacizumab, it is used in diabetic macular edema and wet AMD. It is used in wet AMD. And where you use ranibizumab, you use in anti-cancer. So like your colorectal cancer and non-small cell carcinoma of lung, non-small cell lung cancer, you are going to use ranibizumab. Now you have read 3 drugs under VEGF inhibitor. Number 1, it is ramucirumab. Number 2, bevacizumab. Number 3, ranibizumab. Clear, right? Number 4 is tyrosine kinase inhibitor. So tyrosine kinase inhibitor, you're going to have 2 drugs, sunitinib and your sorafenib. This sunitinib and sorafenib, they have additional function. Apart from inhibiting your tyrosine kinase enzyme, they can also inhibit your vascular endothelial growth factor receptor, very similar to that of your ramucirumab. So what are the drugs? Sunitinib and sorafenib. Remember, sunitinib is utilized in the, okay, how to remember? Sunitinib, S stands for sa, re, ga, ma. We read like sari, gamma, right? So sa is nothing but your sunitinib. So sunitinib is used in the GIST. So gastrointestinal stromal units and pa, ma, pa. So let's remove this ma and re. So sa, it's going to be a sunitinib. Ga is going to be GIST. Pa is going to be a pancreatic cancer. Pa is your pancreatic cancer. So what are the drugs which are going to be helpful for in your sunitinib is going to help in which all cancers? Number 1, it's going to be in your gastrointestinal stromal tumors. Number 2, pancreatic cancer. And where your sorafenib is going to help in your renal cell carcinoma. It is going to help in hepatocellular carcinoma. So where you're going to have this, and here you're going to have another problem, that is going to be your hand-foot-mouth syndrome. So the problem which you're going to get here is hand-foot-mouth syndrome. Hand-foot-mouth syndrome. Now can you tell me what are the causes of hand-foot-mouth syndrome? What are the other drugs you know which causes hand-foot-mouth syndrome? Can you just put in the chat box? We have already discussed the entire hand-foot-mouth syndrome. Can you let me know what is the drug which causes hand-foot-mouth syndrome? Can you let me know what is the disease that causes hand-foot-mouth syndrome? Can you put in the chat box? Hand-foot-mouth syndrome. Which causes hand-foot-mouth syndrome? 5-fluorouracil. Excellent. Number two, from where your 5-fluorouracil is going to be coming? What is the prodrug of 5-fluorouracil? Capecitabine. Very good. Cytarabine. Okay, you have your capecitabine. Excellent. The next one is cytarabine. That is going to be a cystosin arabinosin. Cytarabine. That is also going to cause doxorubicin. Doxorubicin causes. Then you have this sorafenib and sunitinib. These two also causes hand, foot, mouth. இந்த மூணு சேர்ந்தாதான் மெடிசன். இந்த மூணு தரவா இருந்தீங்கன்னா you can score distinction and honors in your medicine exam in your final year. Clear, right? Now coming towards the monoclonal antibody against your EGFR. What is EGFR? Epithelial growth factor receptor. So epithelial growth factor receptor, how you are going to inhibit? Same way, either you can inhibit your epithelial growth factor or you can inhibit the epithelial growth factor receptor and tyrosine kinase receptor. But the drugs that are going to inhibit your epithelial growth factor is going to be cetuximab and panitumumab. Cetuximab and panitumumab. Cetuximab and panitumumab. So these are the two drugs that are going to cause inhibit. They are going to inhibit your epithelial growth hormone, epithelial growth factor. So these are the drugs that will inhibit your epithelial growth factor. And next one is going to be growth factor receptor inhibitor. What is receptor inhibitor? That is going to be gefitinib and your erlotinib. So the drugs that end with tinib, they are going to be mainly inhibiting tyrosine kinase receptor. Okay, any drug that ends with tinib, so suratinib, you have your sunitinib, sorafenib, any drugs that end with nibib, okay, NIB, that is going to be aiming for the your tyrosine kinase enzyme. Similarly, you have your gefitinib and erlotinib. They both are going to inhibit your tyrosine kinase enzyme receptor. Okay, so this is used in the non-small cell cancer of lung with exon 19 deletion. So there are various causes of non-small cell cancer. I have told you in the pathology when I am discussing. Among them, one cause of your non-small cell cancer is going to be your exon 19 deletion. அங்க என்ன drug தருவீங்க? You are going to give you are going to give gefitinib or erlotinib. So remember, so food will be increasing the absorption of gefitinib. So therefore, you can give gefitinib along with the food. Okay. Now coming to the osimertinib. Osimertinib, they are going to be helpful in the small cell lung cancer. But in but what happens? You can also use this in the non-small cell lung cancer, but with 790 nanometer mutation. T790 mutation. With exon mutation, you're going to go for the drug called as, what is the drug you go for in the exon mutation? It is going to be, what is the drug you go for in the exon mutation? The drug which you're going to give in the exon mutation, it is going to be, can someone tell me, what is the drug you give in exon mutation? What is the drug you give in exon mutation? Can you put in the chat box? What is the drug you go for in the exon mutation? What is the drug you go for in exon mutation? Come on, guys. What is the drug you go in exon mutation? Gefitinib. Excellent. So what is the drug you're going to go in your, the next one? That is going to be your non-small cell carcinoma with 790 mutation. There you are going to go for osimertinib. Clear. Now the last one, HER2/neu. This is a very important receptor that is present in your breast cancer. The drugs that are targeted against this HER2/neu are trastuzumab and pertuzumab. So this is very helpful in the HER2 positive CA breast. And what are the drugs that are going to inhibit your tyrosine kinase because of this HER2/neu? They are going to be lapatinib and neratinib. Lapatinib and neratinib. Both are going to cause increase in the QT interval. Next, we are going to talk about the imatinib. Imatinib, they are just a tyrosine kinase receptor of BCR-ABL. Do you remember where will we have CML. In CML, we are going to have imatinib. Imatinib is going to help in BCR-ABL fusion inhibition. BCR-ABL fusion inhibition, you're going to have imatinib. So whenever there is a resistance of imatinib, then you go for the DNB drugs. What are the DNB drugs which you are going to remember? D stands for dasatinib, N stands for nilotinib, and B stands for bosutinib. Dasatinib, nilotinib, bosutinib. These are the three drugs that are going to be given alternate to the imatinib. So alternate to the imatinib, you are going to give dasatinib, nilotinib, bosutinib. Clear, right? These are the tinib group of drugs which is used in the BCR-ABL gene mutation. So that is going to be a very important cause of your CML. Clear, right? Next, you are going to have c-KIT gene mutation. Where will you see c-KIT gene mutation? You're going to see KIT gene mutation in GIST, gastrointestinal stromal tumors, as well as you're going to see in case of what? Can you tell me in which case you're going to see your c-KIT tumor? In your Burkitt's lymphoma also, you're going to have KIT mutation. So in those conditions, the drug is going to be your imatinib. If imatinib is contraindicated or resistance, then you're going to go for sunitinib. Sunitinib, you're going to go for. The final topic of your anti-cancer drug is going to be your immune checkpoint inhibitor. What is immune checkpoint inhibitor? Immune checkpoint inhibitor. This was discovered just in 2018, and Dr. James Allison got Nobel Prize for this 2018 discovery, immune checkpoint inhibitor. So what happened is inside a cell, you're going to have three checkpoints. Number one, CTLA4. Number two, TCR, T cell receptor. And you're going to have PD1. These are the three checkpoints which are going to check your T lymphocyte. Okay, so CTLA4 is going to be a co-inhibitor. PD1 is going to cause inhibition of your T cell proliferation, whereas your TCR causes increase in the T cell proliferation. Who is going to receive the signal? Who is going to give the signal for your TCR, CTLA4 and PD1? So your antigen presenting cells. Whenever there is going to be antigen which is present in your antigen presenting cells, what happens? It is going to present it to the major histocompatibility complex 2. When it is going to be presenting to major histocompatibility complex 2, what happens? It is going to send the signal to your TCR, T cell receptor, and this leads to proliferation of your T cell for guarding, for immunity. But what happens when there is no antigen? What this antigen presenting cells will do is they will activate your CD8086 and PDL1. When the CD8086 and PDL1 gets activated, this CD8086 is going to cause inhibition of your CTLA4. They are going to cause activation of CTLA4. There's not co-inhibitor, there's going to be co-activator. So this CD8086, this is also going to act by increasing the interleukin. They are going to, whenever there's an increase in the interleukin, what happens? They are going to bind with the CTLA4, and they are going to also activate your T cell proliferation. They are going to also activate your T cell proliferation. Now what happens? You have the third one, that is going to be PDL1. This PDL1 is going to inhibit the T cell activation. So this PD1 is also going to cause co-inhibition of your PD1. Now what happened? You have three type of drug. Number one, CTLA4 can be inhibited and it can prevent the cell cycle. It can prevent the T cell proliferation. What it is going to help? Number one, ipilimumab. You're going to have ipilimumab. So this is going to be used in malignant melanoma. Similarly, anti-PD1 antibody, that is going to help in the nivolumab, and you have pembrolizumab, and you're going to have dostarlimab. Okay, three drugs. Remember, nivolumab and your pembrolizumab. Then you're going to have dostarlimab. This nivolumab, this is going to be a malignant melanoma, non-small cell carcinoma of lung, Hodgkin's lymphoma. In the moon condition you're going to give. Similarly, in which condition you're going to give? In which condition you're going to give pembrolizumab? Non-small cell carcinoma of lung. For very surprising, this question was asked in the NEET exam, NEET PG exam. What is this Keynote 199 trial? Keynote 199 trial is nothing but they are going to denote your pembrolizumab used in the non-small cell lung cancer. This is called as Keynote 189 trial. I want you all to remember this. And we have something called as dostarlimab that is going to be used in CA endometrium. Then finally, anti-PDL1 antibody. Anti-PDL1 antibody, it is used in atezolizumab. Atezolizumab, this is used in small cell lung cancer, CA bladder. small cell lung cancer, and CA bladder. Okay, now the last and final topic in this anti-neoplastic or inside your hematology anti-neoplastic in the series which we are discussing, that is going to be sickle cell anemia. Remember, the drug which you are using in sickle cell anemia is hydroxyurea. This is going to inhibit the DNA synthesis. Okay, they are going to inhibit the DNA synthesis. That's why we are going to use it in the sickle cell anemia. What are the other drugs which you are using? So the newer drugs which we are using nowadays is voxylator. Then we are using L-glutamine and we are using crisanlumab. Crisanlumab is a P-selectin inhibitor. L-glutamine is antioxidant and voxylator is going to be a HBS polymer inhibitor. So HBS polymer inhibitor and the Rolex formation can be prevented. That is going to be a voxylator. And what is going to be your hydroxyurea? They are going to be a DNA synthesis inhibitor. With this, we are completing the entire topic. We have completed the entire topic of your anti-cancer drug. I'll give you for 10 minutes break. You can take a 10 minutes break. You can come back at around 12:30. So we will start at 12:30 till 1:15. We will complete a small topic that is going to be your NSAID and your autocoids. After completing your autocoids, let's go for a lunch break. And again around 2 to 2:15, we will come back. We will start discussing the remaining topics, GIT, renal, cardiovascular system. GIT, renal cardiovascular system, which we will be discussing in the afternoon. Are you all clear with this? If you have any doubt, you can post it in the chat box. Okay, so I'm just giving you a break of 10 minutes. You can come back around 12:30. We will take 45 minutes to complete NSAID and all your histamines and all your autocoid chapter. Clear? Thank you. So after a short break, I hope so all are ready. Okay, so we can just go with we can just start with the very important topic that is going to be your autocoids. So now we are going to discuss about the autocoids. Are you all ready? Are you all ready? Can I start? Is my screen visible? Can someone let me know if my screen is visible? And if you can see what I am writing? Aishwarya. Okay, very good. Thank you. So I'm going to start with a very important topic that is going to be our autocoids. Listen carefully. In autocoids, I think we have already covered one particular topic with CNS that is going to be a migraine. So I'm going to just revise this migraine, whatever necessary for your exam. And then let me continue with your other histamine receptors, other drugs. Okay, starting with your 5-HT1 receptor. 5-HT1 is going to be your serotonin receptors. So what is this basically autocoids? They are autocoids or something that are going to regulate. They are going to be giving you a steroidal substances. They are going to regulate all the mechanisms like your blood flow, like your immune system, like your inflammatory system. Everything is going to be monitored by this system called as autocoids. Okay, so that's what we are going to read now. Okay, the first one is going to be a 5-HT1 receptor. I hope you all know this. This is a serotonin receptor 1. 1 is divided into 1A, 1B, 1D, and 1F. This was already covered yesterday. 1A drugs are going to be buspirone. They are going to act as an anti-anxiety drug. Then you have 1B, 1D receptor agonist. That is going to be triptans. So triptans are used in the acute attack of migraine. The drug of choice in acute attack of migraine is going to be a sumatriptan, followed by your zolmitriptan, rosatriptan, and frovatriptan. Then you're going to have 1F agonist, that is going to be your lasmiditan. Okay, then you have something called as 5-HT2. 5-HT2 agonist, they are going to be used, that is called as lorcaserin. What is this lorcaserin? So remember, SER stands for serotonin. Okay, this lorcaserin is going to suppress your appetite. Where did you use it? We use in case of obesity. But what happened is this lorcaserin actually caused cancer. They are posing a risk of cancer, and that is the reason why we are now banned the lorcaserin. Next is going to be 5-H2 antagonist, where we use this 5-HT2 antagonist in atypical antipsychotic. Do you remember? 2A, 5-HT2A. Yesterday we were discussing about this. In case of antipsychotics, you have olanzapine, clozapine. Now tell me, if you are going to give agonist, it is going to be suppressing your appetite and helpful in obesity. When if you are going to antagonize this receptor, what happens? It is going to increase your appetite and causes increase in obesity. So when you're going to give this patient to an obese patient, what happens? They will have an increase in weight gain. There is going to increase in obesity. So So the side effect is going to be obesity, and contraindication for it is going to be in an obese patient, you should not give this olanzapine and clozapine. Then anti-serotonin, you have certain drugs like your ketoserin, you have ritanserin, and you have ciprotandin. So ciprotandin. So these drugs are going to be used as a migraine prophylaxis as well as in your serotonin syndrome. Let's see one important question. A hypertensive patient with a migraine comes to the emergency department with hypertension, tingling sensation, and numbness in the finger. On examination, you found that there is a loss of tibial pulsation. What is a loss of tibial pulsation? Means there is no proper supply of vascular vessel or blood into the peripheral area. So this is going to give you a cling that this is a ergotism. Okay, this condition is called as ergotism. Why there is a ergotism? Let's see. So the ergotism is due to some potent vasoconstriction. Because of the potent vasoconstriction, there is going to be a hypertension and there is going to be a migraine. Okay, so this is given in the gangrene of organ and it causes end artery, especially your fingers. So what is the treatment of choice when there is ergotism? Remember, treatment of choice is going to be your nitroprusside. So what are the side effects of your ergot alkaloids? Hypertension, angina, MI, Raynaud's phenomena, dry gangrene, erythromalgia. These are the side effects of your ergoid alkaloids. Okay, now coming to this one, I told you yesterday itself that I will discuss about this chemotherapy-induced nausea and vomiting today. That's what I'm going to do now. What is chemotherapy-induced nausea and vomiting? So whenever you're going to give all the drugs which we have discussed just before this session, all your anti-neoplastic drugs, all your antibodies, all your vincristin, we have discussed vincristin, we have discussed cyclophosphamide, all these drugs are going to cause nausea and vomiting in the patient. So what is the drug you're going to give in these patients? Number one, you're going to start with the chemotherapy induced nausea and vomiting. An important drug of choice is going to be 5-hydroxytryptamine or serotonin antagonist. What are the serotonin antagonists you're going to give? Ondansetron, granisetron, all your cetron group of drugs. All your cetron group of drugs like your ondansetron, granisetron, your palanositron, all these cetron group of drugs are going to be serotonin antagonists. They are going to be serotonin antagonists. They are going to be given up to 24 hours you can give. So up to 24 hours you can give granisetron and ondansetron, but palanositron you are going to give in the delayed phase, that is more than 24 hours. Clear, right? Now we are going to go to the second one, that is pitons. Just now I discussed about this NK1 antagonist in your chemotherapeutic agent. The NK1 antagonist are nothing but neurokinin antagonist. So this neurokinin receptors are also the important cause of your nausea and vomiting in the chemotherapy patients. So you're going to give the drugs that are going to inhibit this neurokinin. Example, aprepitant, fosaprepitant, rolapritant, and netopitant. So the among them which is given in the IV format, fosaprepitant is given in the IV format. So if this also it is not taking any value, this also is not going to cause any help, then you're going to go for the third one, dexamethasone. What is dexamethasone? It is a steroid. So you go for a dexamethasone steroid in the delayed phase. What is the fourth one? Cannabinoid agonist. So what is cannabinoid agonist, or we call it a CB1 agonist? So you have your dronabinol, nabilone. So dronabinol, labinol, what happens is they will be reducing your nausea, vomiting. But ultava, what happens? Your nabilone will be increasing your appetite. Nabilone increases your appetite. Okay, we have another group of drug called as CB1 inverse agonist. You all know what is inverse agonist, right? So we would have been putting a graph. Do you remember? So agonist is going to be something acting like this. So when this is going to be a normal drug, agonist is going to be something that is going to be acting along your line of your agonist. And what is your antagonist? That is going to be acting like this, or that is going to act, they are going to stop the action of your agonist as your antagonist. Stop the action of this receptor is called as antagonist. What is inverse agonist? It does not only stop the agonist or stop the action of the receptor, but will also cause inverse action of the receptor. If for example CB1 receptor, so CB1 receptor ku agonist nama kudukrom like your dronabinol, nabilone. What does this does? It is going to decrease your vomiting and increase your appetite. But you have some other thing called as rimonabant. This rimonabant is a CB1 inverse agonist. So what it does is it is going to cause nausea, vomiting. So this will cause nausea, vomiting, but this will reduce the appetite. Why I am telling here is this drug was used as a anti-obesity drugs in your USA. But what happened is many people started to go into depression. Many people started to go take a suicide, started to do suicide, and many people had a nausea, vomiting. Then only they identified that it is going this CB1 cannabinoid, when you are going to inverse agonist, they are not only reducing the vomiting, but it is also going to lead the patient to they are going to lead the patient to depression and anxiety. Now moving on to the next question. So this is going to help you to remember the drug-induced Parkinsonism. Yesterday we discussed this question. A patient presented with the emergency department with vomiting, reduced bowel sound, and in turn gave an injection of antiemetic, but that led to muscle spasm, upward gazing of eyes, and bradykinesia, gait abnormality. All these are going to turn towards Parkinson's. But the patient has given some antiemetic drug, that had led to Parkinsonism. What is that? That is going to be a metoclopramide. Hope you all remember in your anti-cancer drug, I gave you a very important tableau column for differentiation. Hope you remember. Do you remember the tableau column which I gave you, that is going to differentiate the two important things? That is going to be differentiating your metoclopramide. We have differentiated metoclopramide as well as what? Can you remember and tell me in the chat box if anyone from yesterday's session, do you remember? We have differentiated two important drugs basically. One is your metoclopramide and we have differentiated the other drug. Okay, metoclopramide and we have differentiated other drug. Okay, so I think so many of them are new for today's session. No problem. I'll tell you the problem with your metoclopramide is what happens. You have something called as your blood-brain barrier. Okay, outside your blood-brain barrier lies your CTZ. CTZ lies outside your blood-brain barrier. But inside your blood-brain barrier, what you have? Nigrostriatal pathway. So what happens is you have two type of drugs. Okay, the patient who is having Parkinsonism. A patient who is already having a Parkinsonism, what happens? When you are going to give or if the patient is not having Parkinsonism also, if you are going to give metoclopramide, metoclopramide can pass your blood-brain barrier. Since metoclopramide can pass your blood-brain barrier, what happens? It can attack on your CTZ receptor also. It can also go and attack on your nigrostriatal pathway. You know that what is your metoclopramide mechanism of action? Metoclopramide is going to block your D2 receptor. Because of that, it is going to block your CTZ as well as your nigrostriatal pathway. When it is going to block your nigrostriatal pathway, what happens? There is no dopamine which is present in the dopaminergic pathway between your nigrostriatal pathway from your substantia nigram to striatum. Because of that, what happens? There is no inhibition of your acetylcholine. So there is going to be hypercholinergic activity. This hypercholinergic activity is the one, there is a muscle spasm, upward gazing of eyes, and bradykinesia. So the drug which the intern would have given without knowing is going to be a metoclopramide. So what is the drug of choice in these patients? So you have to go for domperidone. So you should not go for metoclopramide. Instead of metoclopramide, what is the drug you are going to give? Domperidone. Domperidone is a drug because domperidone is going to act only on D2 receptor present on the CTZ. It cannot cross your blood-brain barrier. Hope you can understand what anti-emetic drug you have to give when a patient comes to you at the midnight. Especially, you should never give metoclopramide. The side effect is going to be, it is going to cause drug-induced Parkinsonism. Unfortunately, the intern has given the metoclopramide at midnight 12 o'clock. You are going to sit as a duty medical officer. What you are going to do for that patient? So I told you that they are going to cause increase in cholinergic effect. So what you can give? A central anticholinergic drug can be given. What is the central anticholinergic drug that is present? The central anticholinergic drug that is present is going to be your benzoxazole. So benzoxazole is a central anticholinergic drug. Is it clear? So this is one applied question that can be asked in the exam. Now coming to the prokinetic drugs. So we will discuss about something called as prokinetic drugs. So listen carefully. We have now discussed 5-HT1 in migraine. We discussed 5-HT2 where we discussed 5-HT2 we discussed in case of your obesity drugs. Then we discussed 5-HT3. 5-HT3 is going to be included in your chemotherapy-induced nausea and vomiting. Now we are discussing finally the 5-HT4. Remember, 5-HT4 is going to be very important in the gastric motility. So 5-HT4, serotonin receptor 4. There are totally 7 serotonin receptor. Out of that, 4th serotonin receptor is what we are discussing now. Serotonin receptor 4 is going to be acting as an agonist. Okay, ma? So what are the agonist drugs? So remember, pride. So all your pride drugs comes under 5-HT4 agonist. So you all know that there is going to be how your gastric and intestinal system has functioned. Whenever you're going to eat food, that food has to go through your lower esophageal sphincter. After that, what happens? Your lower esophageal sphincter has to close. Once the lower esophageal sphincter has to close, what happens? There is going to be acid secretion. After acid secretion, what happens? There is going to be a motility that pushes your food into your intestine. Then what happens? After entering into intestine, there is going to be absorption. After that, you're going to have a bulky mass that has to be pushed into the colon, and from the colon to your anus and your rectum, it has to come out. That is the normal procedure. But what happens? So whenever you're going to have a excessive vomiting, for example, when you're going to have excessive vomiting, when you're going to increase the kinetics, when you're going to increase the esophageal contraction and relaxation, that is peristalsis, what happens? When you're going to increase the peristalsis, that will help you in the movement of your food and other particles in the forward direction. So that is going to be the prokinetics role with your vomiting. Especially second thing, when you're going to have your GERD, gastroesophageal reflux disease. So you're going to have this prokinetic drugs can be given that will help in the forward movement, so that it will prevent the aspiration of the acid outside in your esophagus or aspiration into the lungs. Okay, this 5-HT4 agonists are given. But what was the problem is, we have several pride drugs: cisapride, mosapride, renzapride, etopride, procalopride, tigazocerone. Okay, we have tigacerone. But what happens? The cisapride and tigacerone, both drugs, they are going to be banned in India. Why they banned in India? Because they caused torsades pointus. That is nothing but there is an increase in the QT interval. So in your ECG, QT interval is going to be prolonged. That was the reason why cisapride and tegosterone is banned. What is a common drug used in this family? The drug name is going to be procalopride. Procalopride is a common drug that is used in this serotonin 4 agonist. Okay, serotonin 4 agonist. Now coming to the second drug which is used as a prokinetic drug, that is again your D2 antagonist. So D2 antagonist is used in case of a serotonin. Now you already know what is a D2 antagonist we used in the vomiting. Can you tell me what is the D2 antagonist we used in the vomiting? Can you tell Aishwarya what is the D2 antagonist we used in the vomiting? We had 2 drugs, but one drug is alone we are using, the other drugs we are not using. Can you tell the drug name? Domperidone. Okay, so this domperidone is also used as a prokinetic drug. Have you ever taken this pan-D? So we have this pantoprazole. Some people will be prescribed with pan-40. When you're going to take an antibiotic, what is the other adjuvant drug which is prescribed along with antibiotic? It is going to be a pan-40. Similarly, you have something called as pan-D. What is this pan-D? We are going to give this pan-D in the patient who is going to have GERD. The patient with GERD, we will be going with the pan-D. D stands for domperidone. Domperidone does not cross the blood-brain barrier, so you can use it very well. Okay, then levosulpiride is also another D2 antagonist that is going to be used as a prokinetics. Next, third one, anticholinesterase. You have neostigmine. This neostigmine is going to be used in the post-operative paralytic ileus. So when there is a paralytic ileus post-operative due to anesthetic agents, you are going to give this anticholinesterase, that is going to be a neostigmine. This neostigmine is going to help in the motility of your GIT tract. Then the fourth one, erythromycin. This also I told you when I was discussing about the antimicrobial yesterday. In the YouTube also the video is available. This antimicrobial erythromycin is going to be helping in gastric motility. So therefore what happens, you can give this in the patient who wants to have an increase in motility, or when the patient is having a vomiting, so or an infection with vomiting, when the patient comes, you can very well go for azithromycin, erythromycin, because they are going to be increasing the gastric motility. The third one, metoclopramide. We read metoclopramide, right? This metoclopramide is going to have 3 actions. One, it is going to be having a D2 blocker. The second is going to be, they are also going to act as a serotonin 4 or 5-hydroxytryptamine 4 agonist, and they are also going to act as a anticholinesterase. This is going to act as a anticholinesterase. So remember, when it is going to go block your blood-brain barrier, they are going to cross your blood-brain barrier, and they are going to block your dopamine. Where it is going to block your dopamine? It is going to block your dopamine in the, yesterday I told you, right, when it is going to block your dopamine at the which place in it is going to cross your blood-brain barrier and block your dopamine receptors at the substantia nigra. When this metoclopramide is going to cross your blood-brain barrier, block the D2 receptor at substantia nigra, already what happens? There's an increase in the acetylcholine receptors, acetylcholine neofibers. Now, in addition to it, what you're going to do? You're going to add a anticholinesterase property of your metoclopramide. This will be causing a huge rise in the acetylcholine. Because of this only, you are going to get all those Parkinson symptoms. That is why this metoclopramide is going to cause a drug-induced Parkinsonism. So what is the drug of choice? Again, I am repeating, benzoxazole is a drug of choice. Okay, now coming to antihistamine. Now we have completed serotonin receptors. 4 serotonin receptors are only the interest of choice for us. Serotonin 1 receptor used in the migraine, serotonin 2 receptor used as anti-obesity, serotonin 3 receptors, nausea, vomiting use pandro, and your clozapine, olanzapine, all those antipsychotic drugs. Okay, antipsychotic drugs will be using what? One is going to use 2A receptors. 2A is using antipsychotic and obesity drug, and serotonin 3 receptors is going to be utilized for what? Serotonin 3 receptors. Serotonin 3 receptor is utilized for the your nausea, vomiting in the chemotherapy. And finally, we went to other serotonin 4 receptors, which are used for the prokinetic movements. Hope I have cleared with all your serotonin drugs. Now we are finally moving into the antihistamines. So antihistamines are nothing but they are going to block your H1. So H1 blockers has 2 roles. One, H1 has a role in the allergy. Okay, so histamine receptors is going to have a role in the allergy. Number 1, histamine receptors are going to have a role in the acid production in your GIT. Number 2, they are going to have a very important role that they are going to cause sedation. Number 3. So remember 3 important points under your H1. What are the 3 important points you're going to remember under H1? Histamine receptors. Number 1, histamine receptors are present in your central nervous system. Central nervous system, like histamine receptors causes central nervous system depression, or there is going to be a decrease in the sedation. It's going to cause sedation. Number 2, it is present in your gastrointestinal system. When it's present in the gastrointestinal system, it is going to cause rise in the acid production. What is the number 3 work? It is going to involve in the allergic reaction. Okay, in the allergic reaction. Now what you are going to do? You are going to give drugs that are required to block the, that are going to be required to block the awakefulness. I'm sorry. So your H1 in your brain causes awakefulness. In the central nervous system, when you're going to give C1 H1 blocker, what happens? It is going to cause sedation. So H1 is going to cause awakefulness. H1 receptor, when you're going to block, leads to sedation. That is regarding your H1 present in your brain. And coming to the H1 present in your allergic reaction, they are going to cause allergic reaction. So what you're going to do? You're going to give a drug that is going to inhibit the allergic reaction. So there are two types of blockers. One is the first generation, other is a second generation. First generation are the one that is going to enter into the central nervous system. Second generation are the drug that does not cross your central nervous system or does not cross your blood-brain barrier. So first generation example, promethazine, diphenhydramine, dimenhydrinate. So what are the 3 drugs? Promethazine, diphenhydramine, dimenhydrinate. So this 3 is going to cross your blood-brain barrier. Therefore, the important side effects you're going to have is your sedation. Now tell me, what are the contraindications which all patients you will not give sedative drugs? That is going to be a H1 blocker. Can you name it? Number 1, you will not give it in the driver. Who is going to drive your car? Will you give a promethazine or your diphenhydramine, dimenhydrinate in the patient who is going to drive your car? He will be sleeping while driving and it leads to accident, right? So you will not give it for drivers. You will not give it for children, because children, they have to be alert. They will be active. So when you're going to give a sedative drug, they will be sleeping. So that you don't want. And third thing is going to be in the elderly individual, in a pilot. In the pilot, you should not give. Okay, so this is an example given in your textbook. Why? I don't know why they have given driver and pilot separately. Pilot also you should not give, because if he is going to sleep while driving your aeroplane, what happens? Your aeroplane will be crashing. Okay, so these are the drugs which you are going to give. And what are the important uses of your promethazine and dimenhydrinate? Remember, dimenhydrinate is going to be helping in the motion sickness. We are going to use it as a transdermal patch. Okay, dimenhydrinate patches you will be getting. So this patch is going to be useful, but problem in the Meniere's syndrome. But the problem is they will be causing a extrapyramidal symptoms. They will be leading to extrapyramidal symptoms. So be careful while using that drug. Now moving on towards the second generation. So they do not cross your blood-brain barriers. So sedation will be less. I will not tell it as a complete no sedation, but I will tell it less sedative. For example, cetirizine. So among the entire second generation drug, cetirizine is still causing sedation. You will all would have experienced. If you are going to take a levocetirizine tablet, and if you are going to work, you will never have a full concentration. Why? Because some amount still it is going to enter your central nervous system and they are going to cause sedation. So there is no, I can't tell it as a complete loss of sedation, but the amount of sedation that occurs with your first generation is lesser in the second generation. That is your cetirizine. Cetirizine is a derivative of hydroxyzine. So cetirizine is a derivative of hydroxyzine. You have levocetirizine, most potent drugs. Fexofenadine is a least sedative drugs. Lortadine is going to be another drug. And topical drugs. We have certain topical second generation antihistamines. They are going to be number one, olapatidine, you have azelastine, you have your epinastine, you have your ketotifen. Ketotifen is going to be mast cell stabilizer. So ketotifen is a mast cell stabilizer. Maximum effect occurs in the azelastine and levocarbastine. Levocarbastine is used in the utric area. Levocarbastine is a drug used in the utric area. Just copy down this. Just copy down these two. And you also have some other first generation group of drugs like your doxylamine, which is used in the morning sickness, plus vitamin B6 has to be given, and chlorpheniramine. Chlorpheniramine is a least sedative in first generation. Least sedative in the second generation is going to be your phenophenadine, fexofenadine, and your chlorpheniramine is going to be the least sedative in the first generation. Highest sedative in your first generation is going to be a promethazine, and highest sedation causing in your second generation is going to be your cetirizine. Clear, right? Hope you are clear with the HT1 blocker. H1 blocker. Okay, hope you are clear with the histamine 1 blocker. Clear, right? Clear, right? Afif, Aishwarya, Naveen, are you clear with the first topic that is going to be a histamine inhibitor? Okay, next we are going to move towards the next one, that is going to be your take-home message. So what are the take-home message you are going to take? Number one, in motion sickness, you are going to use diphenhydramine and promethazine oral drug, and diphenhydramine is given as a post-auricular patch. In the sea sickness, when you are going to go for a swimming, diving in your ECR, when you're going to go for your Taj Fisherman Cove, and there you're going to go into the deep sea diving. So they are having a provision of deep sea diving. So when you're going to go there can be a seasickness for the patient, isn't it? So that time you can give them meclizine, cyclizine, cinnarizine. Meclizine, cyclizine, cinnarizine. These are the three drugs which you are going to give for the patient who are going to have a seasickness. Meclizine, cyclizine, cinnarizine. Clear, right? Now you have H3 inverse agonist. There are some drugs called as H3 inverse agonist. So this H3 inverse agonist. Okay, now I have talked about the H1 over. So only one point you're going to remember with the H3, that is H3 inverse agonist. You know what is inverse agonist, I have already taught you. If you have not known, you can just go back general pharmacology YouTube. I have this general pharmacology part 1. In that I have covered what is the inverse agonist. Clear, right? So in the inverse agonist, you have something called as tiprolisant or pitolisant. This pitolisant and tipolisant is going to be a drug given in the narcolepsy. Do you know what is narcolepsy? Don't confuse with narcoanalysis. Narcoanalysis is different. Narcolepsy is different. Narcolepsy means daydreaming. So you would have day sleeping. So daytime sleepiness. So all these are called as narcolepsy. So what is a drug of choice if you ask me? Modafinil is a drug of choice. I have already discussed this modafinil when I am discussing your CNS. But what are the other drugs you can give there? Tiprolizan can be given. Tiprolizan or other drug is going to be pitolisant. These two are H3 inverse agonists. That's all about your H3. Now coming to your H2. I told you, right? H2 is present all along your gastric mucosa. So they are involved in your gastric acid secretion. So what you can do is you can block this H2. You can block this H2 so that the gastric acid is prevented. In which condition you will do that? In case of peptic ulcer disease, in case of GERD, you can go for a H2 blocker. What are the drugs that are going to be helpful in H2 blocker? Ranitidine. You have this cimetidine, famotidine, lafutidine. Or do you all know Rantac? A very famous drug called as Rantac. This Rantac drug is nothing but your ranitidine. So you have only two drugs for your GERD and peptic ulcer disease, which is commonly used to decrease the acid secretion. One is going to be PAN-D, pantoprazole, domperidone, and the second drug is going to be your ranitidine. These are the common drugs which we use as a H2 blocker. Are you clear till now? This comes to the end of histamine. Are you clear with this? This comes to the end of histamine. Do you have any doubt till now? Can I just know if you have any doubt till now? Can you post in the chat box? Can you post in the chat box? So we will be taking just more 15 to 20 minutes. Okay, I'll be giving you break at 1:15 to 1:20 for lunch, and we will continue at 2 o'clock. Okay, we will continue at 2 o'clock. Are you all clear with this? No, sir. What do you want exactly, Aishwarya? Which one you want to repeat? Can you let me know so that I will repeat it? Which part you want me to repeat? Oh, no doubt. Okay. So no doubt you are telling. Okay, right. Okay. So I thought, or I asked you whether it's clear. So I thought you told it's not clear. Okay. Anyway, now we are going to move towards the next one. That is going to be your NSAID. So now we are going to discuss about the next topic. That is going to be your NSAID. Shall we move into the NSAID discussion? Yes. Just hold on. So NSAID, when I'm going to tell something called as NSAID, what is NSAID? They are the non-steroidal anti-inflammatory drug. What is NSAID? They are non-steroidal anti-inflammatory drug. They are going to be non-steroidal anti-inflammatory drug. Okay. Just hold on. I'll just take the topic alone. Just give me a minute. Yeah. Yeah. So NSAID is nothing but they are non-steroidal anti-inflammatory drug. So I'll just tell you this pathway. Listen carefully. You have something called as phospholipids. This phospholipids will be getting converted into arachidonic acid in the presence of phospholipase A2. Phospholipids gets converted to arachidonic acid in the presence of phospholipase A2. Okay, this arachidonic acid, they are going to be going to two receptors. One is your COX receptor, one is going to be your LOX receptor, LOX receptor, COX receptor. Clear, right? This COX receptor is going to be divided into COX1, COX2, and LOX receptor is going to be the other one. Okay, now we are concerned with only your COX1 and COX2. Remember, COX1 is called as your housekeeping enzyme. Okay, so they are going to convert your arachidonic acid into prostaglandins. This conversion occurs in the stomach. This conversion occurs in the kidney. This conversion occurs in the blood. Okay, COX2 is going to be very specific. COX2 is going to be very specific. They are going to be an inducible enzyme. They are going to be induced at the site of inflammation. And whenever you're going to have any pain, any inflammation, there is going to be a pain, fever, inflammation. Why it is occurring? Because of your COX2 in your COX2 activation and leading to prostaglandin. Because of the prostaglandin activation because of COX2. Now coming to your COX1. COX1 is going to be a housekeeping enzyme. So what it does is in stomach, it is going to increase the mucus or bicarbonate production. Okay, so stomach acidity கம்மி பண்றதுக்கு your COX1 is helping, prostaglandin is helping, and in your kidney your COX1 is going to cause rise in the GFR, and in your blood what it does is it is going to cause increase in thromboxane A2 and it decreases your prostaglandin I2. Thromboxane A2 increase it is going to cause aggregation of platelet. Prostaglandin I2 causes decrease in the aggregation of platelet. Because of that, there is maintenance of homeostatin. Thromboxane A2 will also increase. Your prostaglandin I2 is also going to increase. But remember, thromboxane A2 causes aggregation. Prostaglandin I2 causes decrease in aggregation. Therefore, there is a homeostasis that is going to be maintained inside your blood vessel. Are you clear? This is all about your NSAID. Now, NSAID, this is all about your phospholipid arachidonic acid COX-1, COX-2 conversion. Now, what is your NSAID? This NSAID is going to be a COX inhibitor. You are going to inhibit the prostaglandin synthesis. So, where you are going to inhibit the prostaglandin synthesis? From your arachidonic acid into prostaglandin, you have COX-1, COX-2. Both are going to be inhibited. You can have some non-selective COX inhibitor. Non-selective COX inhibitor, they are not going to select which area it is going to affect. So it's going to be non-selective. Therefore, they are going to cause what? Number one, in the gastric mucosa, there is going to be a trouble. Therefore, acidity increases. That leads to gastric erosion. Number two, it is going to decrease your GFR. Because it is decreasing your GFR, it leads to nephropathy. Number three, it is going to decrease the homeostasis mechanism. So because of the homeostasis between your thromboxane A2 and prostaglandin I2, what happens? It leads to bleeding. So what are the three important problems which you are going to get with a non-selective NSAID? Number one, there is going to be a gastric erosion. So NSAID induced ulcer. Okay, it is going to cause gastric erosion. And number two, it can lead to nephropathy. And what is number three? It can lead to bleeding. This comes to the end of non-selective COX inhibitor. So therefore, what we did is we are not using now this non-selective COX inhibitor. Now we are using selective COX-2 inhibitor, because in inflammation, the COX-2 is having a major role and not COX-1. So they are going to use a selective COX-2 inhibitor. So COX-2 inhibitor is going to be called as COXIB. Selective COX-2 inhibitor is going to be called as COXIB. COXIB. COXIB nama solvom. Okay, now coming to the advantage, no gastritis. But disadvantage enna appdin pathina, they are going to increase thrombosis. Why there is an increase in thrombosis? I'll tell you. COX-2 is going to be present in the endothelium. Okay, endothelium. COX-1 is going to be present in the platelets. Okay, platelets. Now what happens? Your endothelium is COX-2 is going to be inhibited. So because of the endothelial inhibition of COX-2, what happens? Your platelets started to aggregate. Your platelet starts to aggregate in the endothelium. Because of this, what happened? There is a thrombosis. When there is a thrombosis, it leads to MI and stroke. That is the reason why this is banned. Now, this COXIB, Roficoxib drug is banned nowadays. It is not given, especially in the people with CAD and your IHD. Therefore, what happens? They checked this and they started to make sure that your COX-2 present in the endothelium is not affected. So what drug that is not going to affect your COX-2 endothelium in the COX-2 in the endothelium? The drug name is coleoxib. Coleoxib. This drug does not cause anything in the endothelium. Therefore, Roficoxib is banned. Now, the only available drug in the selective COX-2 inhibitor is going to be your coleoxib. Coleoxib. Remember, now coming to the third one, that is going to be a paracetamol. Paracetamol is not a COX-1 or COX-2. Paracetamol is little different. It is COX-3 inhibitor. So remember, COX inhibitor in your CNS. So COX-3 is going to be present in your CNS. So what happens when this is inhibited in your CNS? It is going to, okay, so in CNS, there is an increase in the prostaglandin synthesis by your hypothalamus. So what you're going to do? You're going to inhibit the COX-3 present in the central nervous system. You're going to inhibit the COX-3 present in the central nervous system, your paracetamol. So they are going to act as an antipyretic. It is going to act as an analgesic. That is why they don't have any anti-inflammatory reason. So in anti-inflammatory action, it should inhibit COX-2. It is not going to inhibit your COX-2. It is going to just have an antipyretic, because your hypothalamus, pituitary, everyone are going to be interconnected. They maintain your temperature. So there is an antipyretic action, there is an analgesic action, but there is no anti-inflammatory action. It cannot taken at the site of inflammation. So peroxide present in the free radical at the site of inflammation. So there is no para does not act as an anti-inflammatory. Okay, now what happens in the paracetamol poisoning? This is a very common case which you will be dealing it when you're going to sit as a casualty medical officer after completing your MBBS. So I have seen a lot of cases of people who are consuming lots of paracetamol and coming to the OP, coming to your casualty. So when you're going to consume more than 150 mg per kg or more than 10 gram of paracetamol, then it is considered as a paracetamol poisoning. Can you tell me what is the normal dosage of paracetamol? What is the rough dosage of paracetamol in a child and the adult varyum? Okay, let's see. In an adult, you give commonly 650 mg accepted. So what is the drug you should be having a limit in a child? Remember, 0 to 18 years age varyum. When you're going to see a patient, or sometime you can even consider adult. So you're going to give 18 mg per kg. This is the dosage which you are going to give. 15 to 18 mg per kg is the paracetamol dosing. So when you're going to go and sit in a OPD, in a casual, in some OPD, if you are an intern is going, if you are going to be an intern, you will also work outside. You can also work outside. So likewise, if you're going to work in any clinics, so there what happens, you should prescribe paracetamol. Sometime pediatric age group patient may come to you. How you're going to identify? You're going to say 15 to 18 mg per kg is the dosage which you're going to give for the patient. So whenever it's going to be more than 150 mg per kg or more than 10 gram, you consider as a paracetamol poisoning. So what happens to the paracetamol? This paracetamol enters your liver. It is going to get converted to N-acetyl paraquinoimine. So N-acetyl paraquinoimine. So they are going to be hepatotoxic metabolite. So they are going to get glutathione conjugation. So they are going to convert into non-toxic. Is it normal? Okay, wow. So toxic substance, when they are going to add up with the glutathione, they are going to convert into a non-toxic drug. But what happens in some problem? So in some cases, what happens is there is going to be a glutathione deficiency. When you're going to give a overdosage of the paracetamol, glutathione is not sufficient to conjugate. Because of that, what happens? There is going to be a liver failure. Because of this hepatotoxic metabolite, N-acetyl paraquinoimine, there is going to be a liver failure. Now, what is going to be a treatment? You're going to give a N-acetylcysteine. N-acetylcysteine is a drug of choice for the patient with a paracetamol toxicity. So what happens is this helps in the regeneration of glutathione in the liver. They helps in regeneration of glutathione in the liver. Very clear, right? Hope you all know what is going to be a paracetamol doing and all. Now, coming to the non-selective reversible COX inhibitor. So I told you COX inhibitor. So what are the non-selectable reversible COX inhibitor? So drug is going to be piroxicam, you have ibuprofen, indomethacin. The three drugs which have a non-selective reversible COX inhibitors are number one, piroxicam, ibuprofen, indomethacin. They are going to have analgesic property, antipyretic property. In addition, the one which lacked in your paracetamol is anti-inflammatory property, that is also present here. Piroxicam, ibuprofen, indomethacin. Remember, piroxicam is going to be a longest acting drug. Ibuprofen is going to be safe in child. Indomethacin is going to have a high potency. Indomethacin is going to have a high potency. These are the three things which you need to understand. Now moving towards the drug of choice. So where do you use indomethacin? You all know something called as patent ductus arteriosus. You would have read in your anatomy, embryology. In PDA, patent ductus arteriosus, the ductus arteriosus in the fetal blood vessels will be kept open by your prostaglandin. So that is your, so indomethacin. So this is going to be helping to block the prostaglandin. Remember, this prostaglandin will be opening, will be keeping your ductus arteriosus open. Now, if you wanted to, if your patient is going to have a patent ductus arteriosus, what you have to do? After 1 or 2 months, you are going to give a NSAID, especially ibuprofen and indomethacin. When you are going to give ibuprofen and indomethacin, drug of choice is going to be in the patient with child with patent ductus arteriosus. So this you have to remember. Unfortunately, if the same patient is going to, if a patient is going to have a congenital heart disease, in a congenital heart disease patient, what you're going to do till the patient goes for surgery, you should make sure that the blood supply is maintained. Okay, in any congenital heart disease, you should make sure that the blood supply is maintained in the body. So how we are going to maintain? By giving prostaglandin E1. So this prostaglandin E1 will make sure ductus arteriosus remains open. What is the drug of choice? Alprost dil. Dil means heart. In your Hindi, it's dil means heart. So alprosdil, it is used in the child with congenital heart disease. Child with PDA, what is the drug of choice? You go for ibuprofen, indomethacin. Now remember, what are the side effects of all these drugs? It will cause sleepiness. Okay, it is going to cause headache, it is going to cause sleepiness, it is going to cause headache, and this medication will be when they are overused. When you are going to overuse this ibuprofen, that will lead to headache. Now moving on to discuss about the non-selective irreversible COX inhibitor. We are going to talk about the non-selective just 6 more pages, guys. Just stay with me, just 6 more pages. Non-selective irreversible COX inhibitor. First நம்ம என்ன பார்த்தோம்? We saw reversible COX inhibitor. Example is your piroxicam, then we read about your ibuprofen, then we read about indomethacin. These are the 3 drugs which we saw. Now what we are seeing, that non-selective irreversible COX inhibitor. Example is going to be your acetyl salicylic acid or aspirin. So aspirin has a dose dependent action. Okay, aspirin, when you're going to give in the low dose, that is going to be 50 to 325 mg per day. Okay, that is going to cause antiplatelet activity. They are going to be causing antiplatelet activity. But when you're going to give a high dose of aspirin, they will lose this antiplatelet activity. How does the antiplatelet action occurs? See, aspirin is going to inhibit your aspirin, it is going to inhibit your COX. Okay, aspirin at the low dose, they are going to inhibit your COX. You know that it is going to help in prostaglandin formation, thromboxane A2. Thromboxane A2 is going to cause platelet aggregation. Now you are going to prevent the thromboxane A2 formation. That is going to lead to what? That is going to lead to decrease in platelet aggregation, and that is going to lead to antiplatelet drugs. So aspirin at the lower dose, 550 to 325 mg, it is going to act as a antiplatelet drug. When you are going to give it the high dose, what happens? It is also going to act on the prostaglandin I2. I told you, right, there are 2 drugs, thromboxane A2, prostaglandin I2. In the low dose, only thromboxane A2 is inhibited. Therefore, it is going to act as an antiplatelet drug. But when you are going to give more amount, it is going to inhibit also your prostaglandin I2 formation. Because of this, what happens? There is going to be this thromboxane A2 is going to increase the platelet aggregation. Prostaglandin I2 will be decreasing the platelet aggregation. When both are going to be inhibited, what happens? This causes decrease in the platelet aggregation. Whereas when the absence of your prostaglandin I2, there is going to increase in the platelet aggregation. Therefore, there is a maintenance of homeostasis. There is a maintenance of homeostasis between your platelet amount, between your thromboxane A2 and your prostaglandin I2. Therefore, there is no antiplatelet effect. Remember, this is going to be the effect of low dose and high dose aspirin. Now coming to the contraindication of aspirin. Remember, aspirin induces asthma, so it is contraindicated, and bleeding disorder. So aspirin is not used in the hemophilia when there is a clotting factor disorder. What is the clotting factor missing in your hemophilia? Clotting factor 8 and clotting factor 9. Clotting factor 8 is going to be hemophilia A. Clotting factor 9 is going to be hemophilia B. So here what happens? There is going to be no hemophilia A, hemophilia B. You are not going to give aspirin. Now coming to the child with viral illness like your flu, chickenpox. When you are going to give aspirin, that leads to Rice syndrome. So Rice syndrome causes encephalopathy and liver damage. Now coming to the hyperuricemia. Hyperuricemia is in the history of gout. Okay, they can lead to gout. Now coming to aspirin overdose. When there is aspirin overdose, what will be your drug of choice? Aspirin overdose and it will lead to hyperthermia and metabolic acidosis. What will be your drug of choice? Since aspirin is a acidic drug, you are going to give a base. So what is a base you are going to give? Sodium bicarbonate is going to be given. Now the last topic of the day, last topic of this session, that is going to be a gout. Gout is nothing but acute attack of gout. So you're going to use anti-inflammatory drug. What is gout? There is an increase in the uric acid level. This uric acid, when it is increased, is stored as a uric acid crystals. So they are going to be converted into uric acid crystals, and they are going to be stored in the extremities. So that is going to be called as your gout. Now you wanted to decrease the anti-inflammatory effect of your gout in the acute gout patient. So you're going to give NSAID, NSAID, indomethacin. You're going to give indomethacin, that is a drug of choice, but you should not give aspirin. Why? Because aspirin itself is acidic drug, so it will be increases the acidic uric acid converting into a uric acid crystals. So you're not giving aspirin, indomethacin can be given. Number two, you're going to give steroids. Steroids helps in decreasing the inflammation. But what is the exact drug you're going to give? Colchicine. Why is colchicine given? So it is going to inhibit mitotic arrest. So you know that your purines, pyrimidines, they are going to be broken down to form your, they are going to be broken down to form your all your uric acid, and that uric acid is the one that is going to cause a problem. So what you're going to do, you're going to cause a mitotic arrest at the metaphase. So what it leads to, this causes neutrophilic and granulocyte migration and decreases the granulocyte migration. So this is going to decrease the granulocyte migration. And why you need granulocyte? You know that your uric acid is going to be like this, but crystallization is formed by all the WBC and all your cells. So what you are doing, you're going to decrease the granulocytes. When you're going to decrease the granulocyte, that is going to be decreasing the crystal formation. This is the fastest anti-inflammatory drug in the gout. But the problem is you're going to have a bone marrow suppression. Now what you're doing, you're going to decrease the neutrophil. When you're going to decrease the neutrophil by arresting in mitosis, what happens? It is going to cause bone marrow suppression. Similarly, GI epithelium is damaged, leading to nausea, vomiting, diarrhea, and GI bleeding. And third is myopathy. Okay, remember myopathy. Okay, next is going to be, remember this CY3PA4 is the one that is going to convert, metabolize your colchicine. So when you're going to give any erythromycin, ketoconazole, they are going to inhibit the cytochrome P3A4. Therefore, it can lead to colchicine toxicity. Okay, now moving on to discuss about the interleukin 1 blocker. So now we have discussed NSAID, we have discussed corticosteroid, then we have discussed about your colchicine. The fourth drug which we are going to discuss here is going to be your what? It's going to be your interleukin 1. So interleukin 1 blocker, they are only given in the resistant cases. What are the drugs which we are giving? CAR. C stands for cannabizumab, A stands for anakinra, R stands for rilopacept. Also write the same in your anti-neoplastic drug also. So anti-neoplastic we have interleukin 1 increase. So ange also we are going to give CAR drugs. So what are the CAR drugs? Canakinumab, you're going to have canabicumab, and you're going to have anakinra, and you're going to have your rilopacept. Okay, now moving towards the next topic, that is going to be your chronic gout. So what do you do in a chronic gout? Remember, in a chronic gout is nothing but you're going to lower the urate. Okay, so in your acute gout, you are just focusing upon the inflammation. But in chronic gout, you're going to be focusing upon the urate crystals which are formed. So what are the urate crystals which are formed? So they are going to be formed by the purine metabolism. So purine breaks down into hypoxanthine. Hypoxanthine breaks down into xanthine. Xanthine gets break down into uric acid. This is what happens. So for that, what you have? Xanthine oxidase enzyme. Now you wanted to inhibit this xanthine oxidase enzyme so that there is no conversion of purine into uric acid. What are those drugs? Allopurinol. Remember, allopurinol is drug of choice in case of chronic gout. Do you remember the tumor lysis syndrome which we saw in your Burkitt's lymphoma? Yes, in tumor lysis syndrome, whenever you are going to give some drug, so whenever you are going to give a chemotherapeutic agent, what will happen? That will lead to chronic gout. And you have your Leach-Nyhan syndrome. What are the side effects? Side effects are rashes, number one, ampicillin, and your CKD. So it can lead to CKD also. And number two, Leach-Nyhan syndrome, Kala Azar. Allopurinol is also given as a drug of choice in Leach-Nyhan syndrome and Kala Azar. Next, you have something called as febuxostat. So it's also called xanthine oxidase. Febuxostat, just write it. Febuxostat. So here also you're going to have xanthine oxidase inhibitor. So this is also used, but the problem with this is they are having MI and stroke. Okay, then what you can do is this uric acid gets converted to allantoin. So what you can do is either you can inhibit the formation of uric acid, or you can increase the conversion of uric acid into allantoin. So allantoin convert aganona, it is going to become water soluble. So upon water soluble, now you can excrete by urine. So adukku you need an enzyme called as uricase. So what is that enzyme uricase? Okay, you're going to cause uric acid oxidase or nothing but your uricase. So you have certain enzymes or certain drugs which is going to increase the uricase. What are the drugs that you're going to give to increase the uricase? Uric acid oxidase That is going to be a rasburicase. You have that word itself, rasburicase. So you're going to increase the uricase enzyme, rasburicase. They are nothing but recombinant fast-acting uricase. That is your rasburicase. You can give rasburicase as a IV drug. You can give rasburicase as a IV drug. And what is the other drug? That is called as pegloticase. Pegloticase, this is also going to cause a positive stimulation of your uric acid oxidase. This is given in chronic resistant cases of gout. Okay, what is the side effect? Anaphylaxis. We are going to use in tumor lysis syndrome. We are going to use it in tumor lysis syndrome. Is it clear? Now we are going to move towards how this is going to be done. See, or you can do other one. Okay, these are the two things which you can do. One is xanthine oxidase inhibitor can be given, or you can give uric acid oxidase stimulator. That is your rasburicase and pegloticase. Or you can also cause increase in the uric acid excretion. How do you increase the uric acid excretion? By giving probenecid. This probenecid is nothing but they are the helpful in the uric acid loss in the urine. How do they help in uric acid loss in the urine? By inhibiting the organic acid transporter. So what do they do is the organic acid transporter is present in the proximal convoluted tubule. So which is going to absorb your uric acid from your filtrate. Now what you're going to do is you're going to inhibit this organic acid transporter by the drug named uricosuric drug. So what are the uricosuric drug? Four drugs you're going to remember. Number one, probenecid. Number one, probenecid. Number two, when there is going to be benzoneron. Okay, what is the third one? You're going to have your lesinurad. And number four is going to be your losartan. Okay, remember what is this losartan? It is a ARB which is given in case of your hypertension. So when the patient comes to you with both hypertension and gout, what is the drug you can give? Losartan can be given. Is it clear? Allopurinol is contraindicated in acute gout. You should never give it in the acute gout. Remember that. So why? Because as soon as allopurinol is given, they are going to increase the chance of uric acid crystallization. So immediate effect of your allopurinol is they lead to uric acid crystallization. That is why we are not giving. Now the next last topic is going to be your disease modifying anti-rheumatoid drugs. Okay, what is disease modifying anti-rheumatoid drug? So you have something called as rheumatoid arthritis. Okay, you have something called as rheumatoid arthritis. So what is that? It is nothing but it is going to be an autoimmune disease. It is an autoimmune disease. Now in this autoimmune disease or rheumatoid arthritis, there is going to be a factor called as rheumatoid factor. That is the one that is going to lead to activation of inflammation. So what are the drugs you are going to give? Number one, first thing is you have to reduce the pain caused by the inflammation the patient. And second thing, they're going to affect your joint spaces. So you're going to decrease the joint damage and you're going to decrease the joint damage. So two things, you're going to decrease the pain inflammation, you're going to decrease the joint damage. And these drugs must be a long acting, slow acting for 6 to 12 weeks. So initially they were using NSAID plus steroids. Okay, this was used. But now there are some drugs called as drug modifying disease modifying anti-rheumatoid drugs. What are they? Number one, we have read already about methotrexate in your anti-cancer treatment. So they are the drug of choice, initial drug. So they are going to be given 7.5 to 25 mg per week. So they are going to cause dihydrofolate reductase inhibitor or adenosine release inhibitor. Okay, so what are the side effects? Bone marrow suppression, oral ulcer, hepatitis. We have already seen this while we are discussing about the anti-neoplastic drugs. Second one is leflunomide. So this is an alternative for methotrexate. They are going to be dihydroorate dehydrogenase inhibitor. Instead of dihydrofolate reductase inhibitor, this is going to inhibit the dihydrourate dehydrogenase. Because of that, there's a decrease in the lymphocyte proliferation. There is going to be weight loss, teratogenicity and hepatotoxicity. So both of them, both your methotrexate and leflunomide can cause hepatotoxicity. So they are not given in the liver failure patient. The third one is going to be a sulfasalazine. Sulfasalazine is not given as such. Okay, so usually sulfasalazine, what happens? You are going to give as a 5-ASA. This 5-ASA is the it's going to be the active component in your sulfasalazine. So along with this sulfasalazine ASA, you're going to have sulfapyridine. So 5-ASA plus sulfasalazine is the one that is present in your sulfasalazine. So 5-ASA plus sulfapyridine. This is the drug that is present in your sulfasalazine drugs. So among them, 5-ASA is going to cause ulcerative colitis. So 5-ASA is very helpful. It's not going to cause, it is very helpful in case of ulcerative colitis. Whereas your sulfapyride, it is helpful in your rheumatoid arthritis. So drug of choice in rheumatoid arthritis, first is going to be methotrexate. Alternative to methotrexate, you have leflunomide. Alternate to it, you have sulfasalazine. In sulfasalazine, which is the part which is going to help in the rheumatoid arthritis, that is going to be your sulfapyridine. What does your ASA role? ASA is going to be acting as a in the ulcerative colitis. Clear? Next, you are going to have chloroquine. That is also going to be given as a drug of choice. But in chloroquine, what is the problem? You are going to have bullseye maculopathy. Bullseye maculopathy is a problem in your chloroquine drug. Now coming to the miscellaneous drug, you have auranofin, penicillamine, and your azothioprine. Penicillamine is going to be your copper chelating agent. Auranofin is going to be your oral gold compound, and your azothioprine. Last but not least, you have to know some tumor. You have to know some tumor. You are going to know from tumor necrosis factor alpha, TNF alpha drugs. Number one, infliximab, adalimumab, golimumab, certolizumab. You have etanercept. Why you have to know this? They are used in the rheumatoid arthritis. They are going to be used in the psoriatic arthritis. They are useful in the ankylosing spondylitis. They are going to be used in the ulcerative colitis and Crohn's disease. That is why we are reading all these 5 drugs. In this, adalimumab is very important. This is used in the rheumatoid arthritis as well as your ulcerative colitis. So infliximab is given as IV. Adalimumab, golimumab, certolizumab is given as subcutaneous. Etanercept is also given as a subcutaneous drug. So what are the side effects? Remember, they are going to increase the risk of TB because they are going to decrease, they are going to cause TNF alpha inhibitor. They are going to act against the TNF alpha. Therefore, they are having increased chance of TB because there is a decreased immunity. So always screen for the person with TB. Montex test you are going to perform. Interferon gamma release assay is also going to be taken. Hepatitis B reactivation can occur when you are going to inhibit the TNF alpha, and it is contraindicated in class 3, class 4 of congestive heart failure. In skin cancer, melanoma, lymphoma, this is going to be causing. That's why it is contraindicated. So we have something called as non-TNF alpha drug. What is non-TNF alpha drug? Remember ATT for rheumatoid arthritis. Like this, remember A stands for abatacept. Abatacept is a T cell activator, inhibitor, T cell activator, inhibitor. Then T stands for tofacitinib. So do you know what is tofacitinib? It is going to be a tyrosine kinase. Do you remember when I was discussing in your last part of your anti-cancer drug? Okay, then you have your tocilizumab. They are interleukin 6 inhibitor. Sarilumab is also interleukin 6 inhibitor. This drug was used in the COVID-19 to prevent the cytokine storm. So to prevent the cytokine storm in COVID-19, we were using this tocilizumab. Then R stands for rituximab, CD20 inhibitor. What is the other CD20 inhibitor? Do you remember? Ritu is too hot. TOO too much. Ritu is too much. This is what we read. T. Okay. So hope you all remember. Otherwise, I'll just repeat once again. I have no problem in repeating. Kindly note it down. R stands for rituximab. All these are CD20 inhibitor. So rituximab, and IS stands for your ibrutinib, and you're going to have T stands for tocilizumab, and as O stands for, there are 3 O's basically. First O is going to be your ofatumumab, and you have other O that is going to be your obinutuzumab, and what is the other T? Remember, other O, remember, that is going to be ocrelizumab. And what does M stands for? Multiple sclerosis. The drugs that are going to help in multiple sclerosis, that is going to be your interferon. Interferon beta is one drug, and your ocrelizumab. Just remember, in multiple sclerosis, you are going to remember ocrelizumab. You are going to use in multiple sclerosis. These are the drugs that are used in the CD20 inhibitor. Among them, rituximab is used in the rheumatoid arthritis, SLE, multiple sclerosis, thrombocytopenic, purpura, thrombocytopenic purpura, thrombotic thrombocytopenic purpura. In that also we will be using. Is it clear? In that also we will be using. Hope you are clear with all these points. Now you are going to have this all kinase inhibitors will be ending with nib. So tofacitinib, baricitinib, okay, nib, paracitinib, so tofacitinib, all these citinib drugs are going to be your tyrosine kinase inhibitor. So what is the treatment of choice in rheumatoid arthritis? First, you're going to go for the methotrexate leflunomide. So when it is not controlled, go for methotrexate with hydroxyquinine or sulfasalazine, and you can also start anti-TNF alpha or tofacitinib with methotrexate can be given. With this, we are completing all your NSAID and your autocoids. So this autocoid group of drugs is also over. Now after lunch, we will come back around 2:30. We will come back around 2:30 and we will start with the GIT, renal and cardiology. CNS. Okay, CNS was over already. So we will start with GIT, CVS and RS. If you have any doubt, you can post it in the chat box or in my number, personal number, you can message. So after the lunch, we are going to start with the CVS, RS, GIT, okay, and renal. These are the four drugs, the four systems which we are going to cover post lunch. We will start around 2:30 and we will end around 4:30 to 5. After 5, I have sent you many MCQs. You are going to sit and you're going to solve your MCQs. ANS is already taken in my channel. I'll send you the link. You can go and see. General pharmacology is also already taken. So with this, entire pharmacology will be getting over by 4 o'clock of today. Okay, thank you.